Okay, we have Vera Kevic on the podcast. I'm so excited for this. I have been waiting for this basically since we met back in April at the Toronto Spring Baby Show. And we had a lovely, lovely conversation there. And both of us were just like, we have to speak again. And I'm so excited for the listeners to hear what you have to say. And just for setting a little bit of a foundation, some context for people. If you could give a bit of a background of what kind of led you to this work and how you ended up doing this, I think that would be really helpful.
Thank you so much, Dr. Cindy. Absolutely. Same sentiments for me. Since we spoke in April, I was excited. The whole idea, I started listening to your podcast, The Birth CEO. It's totally aligned. So I'm happy to be here. I've been a doula for 10 years, actually. I'm celebrating my 10th year anniversary of Doulas on Bikes. Um,
Nice.
I used to do a whole lot of other work, but then ended up at a friend's birth kind of by accident. And it completely changed my mind frame of what kind of work I want to do. I found out about doula work after I attended this birth with my friend. And it just led me through a wonderful path of finding a whole world of birth related things that are not medical. That's my field, is the part of birth that's not the part that's done by the doctors. I've often been asked, is this a pathway from doula to midwife? I guess that's sometimes a pathway that people take as they become a doula. They're a support person at a birth, and then they work towards having the medical training to be a midwife. And for me, it's not that. I'm very happy being a birth doula, a childbirth educator. Everything that I've been doing the last 10 years has been leading me more and more towards being an advocate for how we birth, an advocate for people in the birth, outside of the birth, and even doing podcasts like this. As soon as you say you're looking to, empower women, even just in the title, I'm here for that.
Nice.
So
Yeah,
thanks for having me today.
of course. I'm so happy that you're here. And I just want people to know that as soon as we met, I was attracted to your booth because you were wearing a shirt that says birthwork is activism. And I feel that so deeply. And I think so many doulas and so many people who are attracted to this work are feel the same way, that it is as we empower women, as we support the families, as we bring babies into this reality with reverence and treat the process with the respect and reverence that it deserves, that it's activism, it's shifting the world in a lot of ways, and it's doing a big service to humanity.
It is. And even if someone doesn't acknowledge that their work in the birth field is advocacy, even if they don't acknowledge that, it's still happening, even if they don't know it. As soon as somebody has a birth doula attend them in a hospital, it already signals to the staff that this person has done a little extra research, has done some reading, has maybe even asked some friends, and now they have a person by their side who's been giving them alternative information other than just the run-of-the-mill stream, right? So anybody who doesn't think that they're doing activism work when they are a birth doula, a birth attendant, even a lactation consultant, pelvic floor physio for prenatal people, all of these things are shifting the paradigm of how we birth and how we ask questions of our providers and how we show up in the birth venue. So birth work is absolutely activism. Yeah.
Yeah, yeah.
I'm glad you said that too, because I do like to wear a shirt that draws people in and wants them to know, why is she wearing that? What does that mean? Another one that I have, and they're all made by this wonderful woman, China Oliver, in the US, who makes these activist shirts. The other one says, build birth centers, not borders. And then I just love how it sparks conversation. Today, I'm
Yeah.
not wearing a very activisty shirt, but doulas on bikes, that too, we bike.
Yeah, yeah. Let the listeners know a little bit about that. Like you actually will bike to people.
I do really bike. I do really bike. We're doulas on bikes. I started this business together with my with one sister, and now the other sister has also joined us. We like to keep it local. We like our carbon footprint low. We help families to also keep their carbon footprint low. My sister Mira, my partner, she teaches cloth diapering, and we love to do baby wearing lessons, and how to make life simple. And we live by example with that. When I bike to a place, I feel like I'm making less garbage in the world. I'm not traffic. I get there faster. And the other day, I actually went 20 kilometers for a client, if you can believe it. But it's summertime and it feels good and it's part of my daily routine. And I love the work that I do. So we really do bike.
Yeah, that's beautiful. Are you ever tired before the birth work even starts because you've just gone for like a 20K bike ride?
It really is a balance. There's some jobs that you really are not doing just for the paycheck. Because if it's for the paycheck, you're going to get really tired and you're going to do the math on every moment that you're working and is it profitable? And I just haven't set up my life that way, to be honest. I really love doing doula work and I love my recreational time. So if I'm going to bike, I might as well bike to the job. And when it comes to birth work, it's taken me a while to get here, but I think those of us who can make it to the 10-year part have managed to revolutionize our lives a little bit so that we are not too tired beforehand. I kind of use doula work as the excuse to go to bed early. No one's going to pay
Sorry,
me
guys.
to go to bed. It's like, you know what? I don't think I'm going to go to bed. It's 8 o'clock. I might be on call. I'm on call. I might be at a birth tonight. If I go to bed at 8 p.m. and someone calls me in labor at 3 a.m., I am so fresh and ready to go. Whereas if I was partying all night, got home at 1 a.m., this job would be very difficult to do. So not saying that you can't have it all. I'm a fan of having it all too. But this work really does actually take a full view on when you're on call, what does on-call life look like? Because people tend to give birth or start their birth process in the middle of the night, and then I do get called without a lot of notice. So you have to be fresh, ready, bag packed, and on the spot, and maybe for 20 hours.
Yeah, absolutely. I feel like birth work is definitely not something you get into just for the paycheck, or else you're going to burn out real fast.
Yeah, and it's not to say that you can't earn money or shouldn't earn money because I do think it's a profession like any other, and if we want to keep people full-time working in the profession, they need to work to pay their bills, right? So
Hmm.
it's an accessibility issue for sure. Doulas do cost money and they're not covered by OHIP. So if you don't have the means for it, you might choose not to have a doula. And I would really love for every person to have a doula who wants one. And it also means that we have to get paid from somewhere. Otherwise, we become part-time doulas who have to look for other work. And I think that kind of divides our attention, right? So for me,
Hmm.
I've been able to be a childbirth educator. I teach classes. I make money through that as well. And then I'm able to really focus in on staying in this industry. All my research is related to this work, reading evidence. It's always relevant, but it's not always easy for people to do that, to be honest. So doulas are not really regulated at the moment. There's no certifying body. There's agencies that will give certificates, but people tend to come and go from it. And there's a perception of doulas as being this caregiver. They like doing it. They're doing it as a favor for a friend or a volunteer. And that's not quite true either, or not for most people who are trying to make a full living out of it.
Yeah, it's really powerful work. It's valuable work. I think there's been recent research coming out that just like having a doula present improves outcomes for mom and baby. So I hope that more people find a way to make it a sustainable way to make a living for them, for
It's
sure.
like anything else that we prioritize, that's of value, right? And I'm not saying that's for every single family, but I know a lot of us, if we drop our cell phone and it smashes, I'm gonna somehow find $1,000 somewhere to replace that cell phone really fast.
Yeah.
Right. And then when it comes to like, how's your birth experience going to go? Well, my partner's going to be there, so I think that's probably enough. And then sometimes second time parents come back and go, well, actually, it didn't quite go as smooth as I thought. So now I want to invest in having extra support at my birth because I didn't like how it went the first time around. So we kind of don't know what we don't know. But, the investment of a doula is probably more valuable than the investment of a brand new phone, in my opinion. And if you
Hmm.
can find it in one place, value it, and you can find it in another place too, is what I would say.
Yeah. Yeah. I often tell people like the average family um, will have like one or two kids, you know, and one or two times in your life you're going to have this experience. Why not get the support that you need
That's right.
for those 2 times. Yeah.
And babies are going to come out either way, right? Like you can't gestate forever. So whether you plan for a doula or plan for your partner there or plan for both, the baby is coming out. So you have the choice of having some doing the things that are going to shape the kind of birth you want, right? And it doesn't guarantee that outcome, but if you know the road plan and then you set up everything for it, at least you have more of a chance to get down that path. If you just go in with no support and not really having done any research, you're still going to have that baby come out, but it's the way you experience it that's a difference, right?
Mhm.
So when you have a doula, you're already discussing ahead of time, what do you want your birth to look like? And for a lot of people, they go, well, gee, I didn't know I had a choice. I'm already scheduled at my hospital and my OB says that I'm going to be induced by 39 weeks. And so I'm getting my ultrasound and then a cervical exam and that's it, right? And
Mhm.
then, you get a doula who says, well, you get to choose all those things because you actually are consenting to everything. So you might as well speak to your doctor as if you're accepting what they're offering to you, because that's what you're literally doing. They're offering you a cervical exam, you're accepting it, that's consent, and then they do it. But the language of the doctor world and the hospital world and even the midwives, all of obstetrics really is a lot of let me tell you what to do, and then we're doing it rather than here's all the choices. So when you have a doula and they say, well, do you want that cervical exam at 38 weeks? And a client goes, what do you mean, do I want it? Well, you don't have to have it. Here's what it's for. It shows you this, 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 and this is what your provider gets from it. And then you get to decide if you want that or not, right? Do
Mhm.
you want the induction? Do you actually think that you need the induction? When it comes to induction, that's definitely on the rise, Dr. Cindy. I'm sure you know if you're anyone
Mhm.
in this, anyone in, and I can't speak around the world, although I wouldn't be surprised if it's similar, but in Toronto, inductions are definitely on the rise since COVID. I really thought that at COVID times that maybe we'd see more birth coming out of the hospital,
Yeah.
right? Okay, people are not so keen to be in infectious areas where there's lots of spreading and people are sick. Let's take birth out of a sick arena because most people don't need to be in that hospital setting. But instead, what happened? We just expedited the process in the hospitals. Let's make it go faster. Let's control the environment. Let's do as much active management of labor as we can, which really starts with let's induce people before they're necessarily at a place where it's dangerous to stay pregnant. In my
Mm.
class, that's how I present it to people. Today, am I safer to stay pregnant or am I safer to not be pregnant anymore? Because there are valid reasons why we induce people when it's no longer safe for either you as the carrier or for the baby to stay pregnant. There's other means of helping people when the two bodies are separate. That's understandable. In symptoms of preeclampsia, it's very clear. It's not safe for the maternal body to stay pregnant with signs of preeclampsia. So we would do the means for that person to no longer be pregnant. But when it comes down to the sort of the gray area, if you were at if you were told right from the early part of your pregnancy, we're going to induce you at 39 weeks, well, there's no opportunity at 39 weeks to do that assessment and go, well, am I actually safer right now to stay pregnant based on the circumstances in this moment today? But we seem to
Mhm.
be in a shift in our practice of birth here where it's just better to err on the side of let's just get it done. Let's just have the baby out because our interventions are not leading to as much mortality as before. Maybe, we used to use this Bishop score to determine whether or not an induction would be viable. Will this induction likely lead to a vaginal birth in the end? And it's based on the body's criteria in the moment that you're inducing, right? How is the cervix? Is there any change in the body that says that you're already in process in moving towards birthing? And then you get a score of 8 or above, great, high chance that you'll succeed with that vaginal birth. Lower than 5, you know what, maybe not, high chance of a cesarean. But the more we become confident in our operative deliveries and our, cesarean births have safe outcomes, it's just easier for our providers to trust more in the systems, the medical processes, and the things that they can actively manage in the labor rather than the spontaneous part of labor where we have to wait and see. And can we
Mhm.
trust our bodies to do the thing it's meant to do, to gestate at the amount of time it wants to gestate? Um, so yeah, we're seeing more inductions for lots of different reasons. And I don't know if all of them are medically sound or not. That's not for the doula to decide in individual cases. But I do think that we're not necessarily thinking about inductions in terms of, is it actually safer to stay pregnant instead of doing that induction? And again, to the
Hmm.
point of, what the doula role comes in to do is to guide in the experience that a person is having at their birth, right? So even if someone's choosing the induction, do they know all the repercussions of it? Have they been told the process of what could happen, the cascade, the chance of leading to things that are not on your original birth wish? If someone was not wishing to have an epidural, but they consent to an induction, a high chance you're going to have that epidural as well.
Hmm.
We don't
Yeah.
necessarily get that whole play by play from our providers when we're being told, hey, it's better to get an induction. Sometimes it's being given to people like, don't worry, it's a simple process. We'll just start it with one technique and then you go home and that'll be so simple. And that's just not the reality, right? There's a cascade that happens from that first intervention to the next and the next. And I actually think sometimes it starts with that cervical exam at 38 weeks pregnancy, by the way.
Interesting. Yeah. This cascade, I feel like many women are unaware of it, and we don't really get that information given to us. And so an induction seems very benign, like, okay, sure. But you don't realize that that leads to something else, which leads to something else, which leads to something else down the
That's right.
line.
That's right. And it starts already by people being told, oh, I don't think you're going to be able to do it. Your body's not going to have the baby out by a certain time. And we know that most first time birthers are not going to have their baby by 40 weeks.
Hmm.
40 weeks, by the way, is not late. That's just the mid range of our normal gestation period. A human being needs between 37 and 42 weeks on average, which is not the full amount of what we could see, right? To make a baby. So we get
Hmm.
to 40 weeks, and suddenly 2 days later, there's a panic that you're late and that all these other health things or concerns are going to arise. And they might, because the research does show that as you continue to be pregnant, things do start to become riskier in certain areas. But also, there's a whole lot of people for whom that doesn't happen, right? So, how do
Hmm.
we determine who we're unnecessarily forcing out of their pregnancy and who actually needs that is a bit different. I like to start my class by asking people, have you ever met anyone who's been 42 weeks pregnant before or gone beyond? And, many times people are like, no, oh my God, is that allowed? I didn't know that was allowed. And I'm like, well, I have met someone because my first baby was 42 weeks plus a day. And I can tell you, she was born and she did not have any of the signs of a baby that stayed inside too long. So it starts with a lot of like fear and breaking down our trust in our own body. So if I already think there's no chance that my body is going to have a baby on its own, that I'm going to need that nudge, then I'm going to get bored of my pregnancy too. So by the time 39 or 40 weeks comes along, I'm tired, I'm not sleeping so well. Sure, you know what? Yeah, it sounds fine. Let's just get this done. Let's just get the
Hmm.
show going. But if somebody was told, hey, by the way, sometimes an induction might take 2 days, you might end up having every intervention. We can't decide that from the start. We certainly cannot know if a person will start an induction with a Foley catheter, which is the kind of the dangling carrot that is sometimes used by providers. The Foley catheter is a thin tube that's inserted into the cervix, and then there's a ball at the top of it filled with saline, and pressure from inside the cervix is pushing down to hopefully open the cervix to the size of that ball, which is about 3 centimeters.
Hmm.
It's not medicine in your veins. It might not even start your contractions too hard. So it's kind of an easy sell, right? You can even go home with it in most cases. They start in the evening. You go to the hospital, they put in a Foley catheter, everything's great, go home, wait for it to fall out, and then labor will start. This is how it's kind of presented. But the truth of the matter is, in most cases, the Foley catheter is not enough to continue labor or to even get you into active labor. And if you've made the decision to be induced that day, it's because hopefully you've made that good choice to say, you know what, it's actually not safe to stay pregnant, which means no matter what, I'm going to continue the process to no longer be pregnant. But
Hmm.
somehow in the psychology of it, it's like, okay, well, I'm going to start with this Foley catheter. It seems pretty non-invasive. Seems like a simple enough, not too far off of my natural plan for my birth. But the truth is, then you're given a timeline. Okay, if it doesn't fall out by 6 a.m., come back to the hospital and we're going to break your water and start Pitocin. We don't hear that in the doctor's office when they're telling us, hey, if you're not already Your baby's not already born by 39 weeks. We're going to start this process. You show up at the hospital, you're like, great, I'm just going to get a Foley. If you don't have any dilation happening, you can't start with the Foley catheter. So our doctor is already giving us sort of a false, I don't even want to say false, but they're already giving us a scenario that might not be true. And they know it might not be true because it really depends on the landscape of the body on the day you're starting the induction. If you don't have
Hmm.
any dilation, you're going to be offered something else to start the dilation process before you can get the Foley, which is probably a prostaglandin, an artificial prostaglandin. And then that would lead to the next thing and the next. Because if you are already on that pathway, I cannot be pregnant after this moment, that means we're going to do whatever it takes to bring out your baby. And as soon as we start an induction, your chance of a cesarean greatly increases.
Hmm.
If
That
it was
cascade
that
again.
way, that's the cascade, right? So
Mm.
started with I was hoping to start with the Foley. I showed up at the hospital. No, they had to give me a prostaglandin gel first. Okay. That one's either Cervidil or misoprostol, which I know in the US, they talk about misoprostol in a very different way than we do here. They do use that in the downtown hospitals as a way to induce labor or to get it started or to even sometimes augment and progress it. I heard a midwife in the US recently, she called it the abortion drug. I'm like, that makes it sound so, but
Yeah,
we use that to expel birth matter in those
true.
cases as well. And it's the same drug that we use to expel a full-term fetus as well. So there's controversy to some of these medications, but once you start that prostaglandin gel, that might be the only thing that you use throughout the whole labor, but it might be just until you get to the point where you can get the Foley, and then that gets you to 3 centimeters, and then you want to have more contractions, and then that's done by the Pitocin drip, which comes on in a schedule, right? Like when we have oxytocin flowing from our own brain, it's given to us in a way that you get the oxytocin, it gives you the uterine contractions, and then you've got other receptors that come in and help you to cope with that sensation. When
Hmm.
it's given to us through an IV, every 20 or 30 minutes, they're increasing the dose of Pitocin. We don't really have a chance for our receptors, our endorphins and our adrenaline to catch up and go, oh, hey, let's help you cope with that. Instead, you're getting this artificial drip, and then your cortisol levels are rising because you're all anxious and afraid. And the body is trying to balance these hormones, and it's really hard to stay on top of them and cope. And
Yeah.
by most of the time in the hospitals, when we're administering an artificial oxytocin, the gold standard is to get people to be contracting 5 times in a 10-minute span. So 5 contractions every 10 minutes in a spontaneous labor is close to what it looks like at the end of a spontaneous labor. So if I just went
Hmm.
from my own and my contractions kind of went slow and steady, by the time I'm 10 centimeters and ready to push, I might have that kind of contraction pattern where every 2 minutes we're contracting. In a Pitocin drip or an artificial oxytocin drip, we're getting a person to have that contraction pattern, but their cervix is nowhere near ready to push that baby out. So it's not very realistic for a person to expect to get the contractions given to us from an IV, but then have our body be able to cope with it without also having an external IV to help, meaning the epidural.
Yeah,
Once
that positive feedback isn't there.
That's right. And then
Mm.
once you're on an epidural, now you're limited in other ways. You're lying down. You do have position change options. And when you have a doula, we're really good at rotating that body and using the tools like peanut balls in the hospitals and, helping the body to continue for the baby to descend and gravity to help and all those things. However, it's not the same as being upright. It's not the same as feeling the contractions on your own and being able to cope and moving the way your body wants you to move. In labor,
Hmm.
I meet people where they're like, oh, they're not comfortable in a certain position. And until they raise a leg up and have this, off-centered balance, to rebalance, they're doing something that their body wants them to do because they can feel those sensations. As soon as we're on an epidural, we've lost that sensation. And for the most part, we do it because we're tired and it's hard to cope and we want to sleep. So that's fine. But then when it comes to 10 centimeters dilation and pushing, now we're also limited in our movement, in the ways that we can be upright. Some people can be upright on their knees on an epidural, but it really depends on how much strength and stability you have in those limbs, right? And
Hmm.
if you're not in a position where you can comfortably push the baby, and then there's like, do we need to help? And by the way, when a doctor asks to help during pushing, they don't mean thoughts and prayers, Dr. Cindy. I'm not
What do
sending
they mean?
prayers when they're like, come on, can we help? Let me help you. They're either going to do perennial pressure to direct some
Hmm.
everywhere to guide their breath. They're going to do vaginal stretching, which evidence shows increases tearing. It's like trying to put on a turtleneck. Here, let me help you put on a turtleneck, Cindy, by stretching the top of the turtleneck, even though it's this part that we're trying to get through, right?
Right.
So
Yes.
this vaginal stretching is helping. An episiotomy, where they cut the labia, is considered helping in their
Mm,
terminology, or using a vacuum or a forceps extraction. Otherwise, how else are they helping, right?
mm.
So
Everything you're saying is like is coming back to informed consent.
absolutely, absolutely. And what are you consenting to? Because you consent to everything. You really do.
Mhm.
And, I've been in labors also where most people don't want an episiotomy. Nobody's choosing, like, sure, sure, do it. I'd love my labia cut, says nobody, right? And in the cases where I've been the doula, I've seen it happen a couple of times where the provider just moves the scissors closer. They have the whole birth tray of tools. And,
Mm,
they know what they're doing. They're monitoring, okay, what's happening. They're guessing if the baby is moving, especially on an epidural. It's like, you and I have talked about the hospital bed. It's designed for the doctor to be able to have a great view, and the
mhm,
sterile equipment to be right here, and access. If you have enough time to move your tool, if you have enough time to pick up your tool from the surgical tray to move it closer to the person's body, you have enough time to speak the words. I'm fearing that I may have to give you an episiotomy,
mhm,
even if it's just to state it, not to ask. Although really it should be, my advice would be that we give you a cut. Do you agree? Right?
mhm.
They should be asking you, but what happens instead, they move those scissors closer, and then in the moment, boom, boom, it's done, and they're just going to ask forgiveness later. I'm so sorry, I had to do it. Time was of the essence, and I didn't have
Yeah.
time to say it to you. And sometimes when you have a doula, we see it, and sometimes we don't. And sometimes I wonder if we're on the verge of being kicked out, right? So there I am. I've seen the scissors move. I'm reminding the client, do you want to remind your doctor your views on episiotomy? Because they've just moved the surgical scissors closer to your body. Boy, doctors don't like it when I say that.
I don't think so,
We
no.
have enough time for that conversation. They had enough time to say, hey, I'm wondering if I might have to use this tool of mine. I know you didn't want it, but I might have
Yeah,
to. And then it
yeah.
gives the person a chance to say, why do you have to? What happens if you don't do it? What are the alternatives? And the alternative is to move your body and get into another position. If someone's been pushing in one position for more than 3 contractions and it's not moving the baby, why are we staying in the same position until we get to the point where our practitioner is going to offer one of those kinds of helps? So
Mhm,
again, back to that question of the interventions and the cascades. Once we are already on that pathway, I need to get my baby out, and now I'm on an epidural, and now I'm limited in my movement, and now we got to get this baby out, and my practitioner is only doing a certain thing. How are we gonna stop that cascade, right? If
yeah.
I can't push that baby out, I'm going in for a cesarean, because one way or another we need to have that baby out. And by the way,
Mhm,
there's other complications along the line that come up. Will your food be limited? Are you going to be exhausted with no nutrition? World Health Organization says we should not be limiting food and drink to women in labor, to birthing people. We do it in every single hospital that I've attended in Toronto. As soon as someone is on any kind of medication, as soon as you're on the epidural, only clear liquids. I had an anesthesiologist once hold the jar of soup broth up to the light to say, oh, I'm not sure if I could see through it. Like, we're so into our checklists that I had to say, doctor, can you explain again what the purpose is of having clear liquids? Like, if it's for asphyxiation, you know,
mhm,
then let's say it's because we want to make sure that you don't have a full belly. And then someone gets to decide, how much do you have in your stomach? What are you eating? Is a honey stick going to have some kind of indication? And then the other part of that is, on the one side, they're saying, oh, everything is so benign, let us help you. But then they say, we don't want you to eat. So
mhm,
that what I'm doing, the interventions you're offering, have a high chance that I'm going to end up in a cesarean. You didn't tell me that before, but now you're limiting my food and you're putting me on constant monitoring. That elevates your pregnancy. What might have been a low risk pregnancy going into a low risk birth is now a high risk birth, because we're monitoring you continuously, because we're afraid you might throw up in surgery. So here I am thinking, oh, I'm just having a regular induction ready to push my baby out at 10 centimeters. But if I can't eat, it's because you're afraid I might already not be able to push. So all of these tiny little droplets of doubt in our mind, right? We can't have you do that just in case, just in case,
mhm,
just in case. It's like, oh, well, so you already think I'm not going to complete that way either. That's how
mhm,
sometimes it can feel, right?
mhm. Yeah, and the people's perception around the birthing person can impact them, even subconsciously, like what they're perceiving, how they feel towards the birth process in general,
That's right.
trickles into their experience and can impose some of that self-doubt on the person who already is scared, especially if it's their first time, or maybe they had not a great experience the first time and it's their second baby, right? Like they already have that doubt in them.
Even if it's our fifth baby, by the end of pregnancy, our hormones are so high in our body. It's like pregnancy just before birth is the highest concentration of all of those hormones. It's really hard for us to be processing and using that analytical part of our brain to be like, wait a second, am I doing the right thing? Are they in my best interest? We're trying to do all these calculations at a time when our body is actually trying to get us to not do that. So it's a
Mhm.
vulnerable time for even the most badass birther. Even
Mhm.
the person who's like, yeah, rah, rah, I'm going into this with, I know exactly what I want and what I'm going to get. In the moment,
Mhm.
we don't know how those hormones are going to impact us and have us be in such a vulnerable state that it's hard to even, want to disagree or speak up or assert ourselves. This is where the partner role becomes very important, right? Who are the support people surrounding you at the birth? Do they know what your deal breakers are so that they can assertively speak up? Because, one of the things we're not talking about enough is the trauma of partners after birth
Mhm.
and all of the things that they had to witness and repeating afterwards. You can't help but relive your birth experience. My first one was 20 years ago. I still think back on like the different aspects and when did I say yes to this? And if I hadn't done that part, would it have led me down a different road? And partners have the same experience. Why
Mhm.
didn't I say no to that thing that I felt badly about? Why didn't I say something when the student came in? Why didn't I intervene?
Mhm.
Like from everybody in the room, it can be impactful when the nurses and the doctors and the midwives are speaking in a certain way. They sometimes take for granted the weight of their words and how impactful it is. For instance, a nurse coming in and saying, "Would you like an epidural?" Might be for her no big deal, benign thing for a nurse to say. They offer epidurals. 95% of people in Toronto hospitals birth with an epidural. It's very common for a nurse to expect that a person will want that. From the body who's listening, so I'm in labor and I've been doing my best and I'm working so hard and I'm, the affirmations in my head, I can do this, I'm working so hard, I got this, I'm so strong. And then the nurse comes in and says, "Do you want an epidural?" For some people, that sounds like, oh, the medical professional who sees this hundreds of times has watched me labor and thinks I need it now. So I
Mhm.
must get it now because I'm at the point where I've done too much or I can't do the next part. She thinks I'm not going to be able to do the next part of labor. This isn't the hard part yet. Like we start
Mhm.
to do all sorts of interpretations of what our provider said. Sometimes even it's their facial expression. I don't know that they notice sometimes when they have a look of pity on their face. Oh, do you want an epidural yet? It's like, don't pity someone in
Yeah.
labor. That's our powerful time. Just because I look like I'm going through something hard and I'm enduring the hardest thing I've ever had to endure does not mean I'm suffering. And it does not mean that I need your pity. I don't need to be told, hey, this is a good time to have an epidural. Most of the time, they don't say that. They just offer, would you like one? And then how are you hearing it? But again, in that hugely elevated hormonal state, very vulnerable time, especially for first time birthers where they don't know what it's like or what the end part is going to feel like or be like, you hear that question, do you want an epidural? And we make up a whole lot of stuff about it.
Mhm. Yeah. I remember during our conversation at the baby show, you were like, it is human nature. If you know that there is something that will relieve you of the discomfort that you're experiencing, even if your plan, for the whole 9 or 10 months was that I don't want an epidural. It is human nature when you're in so much intensity and discomfort to want that. Like if it keeps being offered to you,
That's right.
then you're more likely to say yes to it because
That's right.
as you said, you're thinking that the staff believe that you need it and you're in discomfort. So of course, we want to relieve the pain. We want to move away from pain.
That's right. And then the person also wants to do some math. They get a cervical exam. They're like, oh, surely this is the end. Surely this is the most intense it's going to get. I surely am 10 centimeters. And then they get a cervical check and they're told maybe 5 centimeters or 6, which is a whole lot of work, Dr. Cindy. By the time someone gets to that stage of dilation, there's other things happening with the cervix, the shrinking, the body, the baby descending in the body. There's lots of other moving pieces, but we tend to fixate on that number 5. And then we do the math. Oh, well, I'm only halfway there. So if it took me
Mm,
15 hours to get to 5 centimeters, am I going to have 15 more hours for the next 5 centimeters, which I know is going to be more intense? And then we think, okay, well, I don't have that much in me. I better just get the epidural now. Where the truth of the matter is, we don't actually know how long that second part of labor is going to go, because that tends to be a bit faster. And then if we know that there's pain relief available, again, it's like, well, I can't do that for even 5 more hours, but you don't
yeah.
know how long it's going to be. We don't know the size of your labor. If I could tell you this is the size of your labor, you can save a slice for the end. But we get to the
Mm,
point where we think we're already done, and then we have to pull it out of nowhere and go beyond. And I've been at home births where, especially that transition period, when a person is between 8 to 10 centimeters, so the body is really getting ready for that final stretch, getting ready for the second stage of labor, it's a highly emotional time. It's a little bit stressful for people. They can be very flighty feeling, ungrounded. I think that's the part that we like to show in the movies, where people are panicked and, I hate my partner, you did this to
yeah.
me, don't touch me. And, that kind of drama part. I think that's sort of taken from the experience of 8 to 10 centimeters, where even in a home birth, that's generally where people start to doubt what they've decided. Oh no,
Hmm.
I've made a mistake. I should have been in the hospital. I should have had an epidural. Maybe I shouldn't have done it like this. Oh no, what should we do? And, in the home birth scenario, we don't have an anesthesiologist knocking on the door in half an hour saying, I can give you an epidural. And a home birth, it's like, great, no problem. We can change the plan anytime, right? You are the boss of your birth. We can go to the hospital and get an epidural anytime you want. Let's get your pants on. Let's get your underpants. Let's get your shoes. Let's get your bag ready. Charger, cell phone, is everything packed? Oh, okay, forget it. I'm already pushing. Right? By the time you
Exactly.
go through all that, if you've been at a home birth, you're in your own space, you're comfortable, you might even be totally naked, you're in the bathtub. Okay,
Hmm.
you got to get out of the bathtub. Let's get you dressed. Let's get into the hospital. Let's go get the procedure done. Of course, someone can do that if they want to. But in a home birth scenario, usually if it's already in that transition phase, by the time we even start to make that conversation and move, boom, we're at the point where we're pushing and there's no point in leaving. If we're in the hospital, it can be expedited a lot faster than that, of course, because we're already equipped to be getting that kind of help. So
Hmm.
yeah, we're conscious human adults, for the most part, adults having babies, and we're awake for the process. And when you know that there's something out there that can just like give you a nice little sleep, continue the process of your body being in labor, wake up and push out your baby, we kind of want that. But again, the epidural doesn't come without some complications, right? It's not a perfect design either. It doesn't always work. Sometimes it has to be a lot of medication. People are shocked when they find out that fentanyl is in the epidural.
Yep.
Nobody's advertising that, are they? The doctors are not telling us that. And I'm not trying to vilify someone who takes an epidural. It is a tool available like any other tool available. And I'm not a fan of people asking you ahead of time, are you going to get an epidural? How do you know if you're going to use the tool?
Hmm.
If you need the tool, it's available. If you can avoid the tool, there are benefits to avoiding the tool, right? There
Hmm.
are benefits to having a spontaneous urge to push. There are benefits to having full mobility of your body. There are benefits to not having to have continuous fetal monitoring, which also comes along with an epidural. There are
Hmm.
benefits to not having saline into you, which is also a requirement of an epidural. All of these things are not necessarily given to us as the full picture before we go into birth. So we think, well, I'll try and avoid an epidural, but if I get one, I get one, because that's just how people do it.
Hmm.
I mean, if we go into birth thinking I'll do my best and I'll try and avoid an epidural, I think most of the time that ends up in an epidural, right?
Yeah.
It takes a little more of a resoluteness of, I don't need that until I need it or unless I need it. I'm not using it until I need it, rather
Hmm.
than I'm going to try. If you're just trying to avoid it, that means you're trying to have an easier labor, and most labors have some element of difficulty. And
Oh
I don't
yeah.
think we're even teaching that in the classes necessarily. Like, why are we sugarcoating it? Labor is not that easy.
Mm.
Not that easy. I personally did it twice. The second one was not all that easier, by the way. It was it was definitely faster, but
Mhm.
emotionally, it was way harder. right? I
Mm,
remembered things. And by the way, I managed to do both my labors without an epidural. And it's not because I'm strong, it's because I had a well-positioned baby, a really good team. And 20 years ago, when I had a midwife, in order to change my mind and have an epidural, that would have required me transferring care to the OB team at the hospital where I was birthing. And that was a big motivator for me to stay off the epidural as long as possible. And I
mm.
was really close, really, really close. Honestly, I think if it had been another half an hour, I would have been like, call it, done,
Yeah,
call it.
yeah.
Because the truth is, it's not easy.
Mm,
But the other truth is that we can do hard things. But
mhm,
I don't know that that's the message our providers are telling us. They're saying, don't worry, we've got tools to help you. You can have an epidural, rather than saying, it's going to be hard, but you know what? You can do hard things. So give it a go,
mhm,
right?
mhm.
We can do hard things and survive it.
Yeah. How about the sentiment that it's easier on the staff when someone has an epidural? Have you heard that?
Yes.
Mhm,
I imagine, I mean, I've never been that staff person, so I can't say firsthand what it's like to be a nurse working with or without an epidural because I'm adjacent to that role.
mm,
But from what it looks like to me, it is less work because there's predictability.
mm,
Uh, it comes together with constant monitoring of the fetal heart rate and the level and consistency, like the frequency of the contractions. And once you're on a TV screen monitor, that means that they're also monitoring that person's progress from the main desk, the nursing
mm.
desk. So it doesn't require the nurse who, by the way, they're one-on-one, right? As soon as you have a birthing room assigned to you, you have a single nurse assigned to you as well. They come and go out of your room because they also have other reasons to assist other teams periodically, but you have that one nurse as your nurse. If you are not on an epidural, it is more likely that you need some hands-on care, that you are not being continuously monitored, which means you need intermittent fetal monitoring. So every 15 minutes with the handheld Doppler, the nurse is coming in to listen to your baby's heart rate, to chart. It's more frequent touches. If you're on an epidural, now they can actually let you relax. You're going to sleep for a couple of hours. We don't need to bother you. If the monitoring shows any kind of anomalies to the heart rate, we're going to come and address it, but we don't have to worry because we see everything from our nursing station. No worries. And the person is not likely to need extra help in coping because now they're not feeling the sensations of labor, so they can just relax and sleep, not likely to need as much from the nurse. Now, again, I'm saying that not having done the nurse's role, maybe there's more charting. Maybe there's more, they need to do more IVs, and, they have to replace the saline bag when it beeps, and the fentanyl bag when it's empty, and all of those things, right? So I shouldn't speak firsthand. Is it more work? But from the perspective of hands-on with the laboring person, it seems a lot more relaxed and on their timeline and on their schedule. Then it's like, okay, every 4 hours we'll empty your bladder. If it's an in and out, we're going to check your temperature, make sure you're not getting a fever, check your
Mm,
dilation every few hours to make sure things are progressing, increase the dosage of Pitocin every 20 or 30 minutes. And it's sort of just a little more on a regimented timeline checklist rather than let's just wait and see when your water breaks on its own. Let's just wait and see how frequent your
yeah,
contractions on their own. Let's see how the intensity is being managed. It's a
mm,
little less hands-on for them.
yeah. Much more predictable, it sounds like.
Much more predictable. That's right.
Yeah. You said something I want to dive deeper into, and you said like much more touches. And I remember us discussing that when we first met. And I think that's a great way to frame the kind of birth experience that women are looking for. And I'd love for you to elaborate on that because I really enjoyed how you described it.
Yeah, thank you. I love this idea too of touches because I hadn't used that before early on in my career either. But the more I've been working, it doesn't make sense to me to use words like natural birth, especially when a lot of people are not starting their conception spontaneously. So then the idea of, is my baby natural? Is my body doing its natural thing? I don't really know what the difference is, to be honest, but it doesn't seem to fit necessarily. It's not so black and white like that in birth, right? So to think of it as, touches, because even interventions, when we think of interventions, it sounds like hard, fast, horrible things, right? Like
Mm,
medical things like interfering, right? An intervention for me is anything that is taking you off what you would be doing if nothing happened. So to explain it as touches could be even that cervical exam from the doctor's office. It's something that's giving you new knowledge that might make you make a new decision. An ultrasound that you take is a touch. Who's at your birth saying things, like that's even a touch, because it's touching you in a way that's like, oh, I didn't know that, and now I'm going a different direction, right? And then it gets to be more like, okay, so if I'm planning my birth and I think of it as I want a natural birth, then as soon as one thing goes off that natural plan, it's all out the window, and now I'm having unnatural birth, right? Like, I don't really know what that means. But if you have it as touches and I want to minimize how many touches, then it's not an all or nothing, right? I'm going to say yes to this touch because it makes sense to me. I'm going to say no to that touch because it doesn't make sense to me, rather than an all or nothing kind of feeling to it. And everything is going to actually like have some kind of effect and impact. We're doing it because we want an impact in one way, right? If I consent to my water breaking, it's because I want to nudge my labor along to be moving faster. That's one less thing. And maybe my baby will descend. It's a touch that I don't want necessarily, but if I want it, it's because I want to get to that next thing that it's leading to. Everything that we intervene is leading us to the next step. It's just a matter of, do you want it to go that way? Is it controlled? Is it going to go possibly 4 ways, right? You got to know what the risks are for each touch that we're getting. But I'm in the spirit too of, I want people to leave their birth feeling empowered by their choices, regardless of what they had to make. And in obstetrics, you have to make critical decisions on the fly. And so if you think of it as, okay, well, I said yes to this one thing, but we'll see where it leads, and I'm not going to say yes necessarily to the next thing. You can make that choice based on the moment and circumstances, and know that you didn't have any other circumstances to make that choice from, right?
Right.
So, okay, that touch I said yes to because I really needed it in that moment, and I'm going to feel proud that I made that touch because I couldn't choose any other way, right? I don't know. For me, I like it as touches because then it can be a lot, it could be a little. You get to decide how many and when. You do
Yeah.
consent to everything. One of my doula colleagues has changed her birth wishes form. So you know how people do a birth plan. You can call it a birth plan form, birth wishes form. My colleague at sorry, I'm going to forget what her business name is called now, of course. Jen LeClaire, she's my good doula friend, Jen LeClaire, Mama Bear Doula Care. She has her document is called your conformed consent form. So it keeps it's basically like a birth wishes, but all of the things that are your birth wishes are the things that you're consenting to. I consent to have a vaginal birth. I consent to trying nitrous oxide in my labor. I consent to position changes for when I'm pushing. I consent to cervical exams at these projected times. Like, to call it an informed consent form, these are the things I'm saying yes to going into my birth. I can change my mind. I might say yes to other things, but I like that idea of everything that I'm already telling my practitioner that I want is what I am consenting to. Everything else that you want to offer to me is a new thing that I get to hear what you're offering. I get to ask all my questions. I get to feel comfortable about my choice, and then I'll consent to that new thing. Doctors, midwives, and nurses sometimes don't have the language of consent. So I really like that idea of, I might with pride steal it from her and put that somewhere like birth wishes / this is what I consent to so far, right? Because that's basically what it's saying. This is what I so far consent to. But a lot of times I hear our practitioners saying, hey, here's all the information that I want you to have. Consent, okay? And rather than, informed consent is not about giving me information. It's about me feeling informed about it. So we consent to everything, whether we think we are doing it or not, right? We sign that form on the way into the hospital, save my life if you have to, right? And then it's interpretation what they had to do to get there.
Right. I want to bring up something that we discussed also the first time that I met you, and you were talking about one of the most like wild births that you've seen. And I don't know if this is triggering or like jogging your memory, but it was the profession of the birthing person. Do you know what I'm talking about?
Oh, yes.
Yeah. Can you talk about that?
So I did have a client who was a medical malpractice lawyer, and the staff all knew what what this person did for a living, and I have never seen so much talking from the doctors and bringing in another doctor. And are you sure you understand all of the implications of choosing this? And here are the risks, and here are the benefits, and here are the, are you sure you're okay to choose this? Do you know what you're consenting to? My mind was blown. I'm like, OMG, please treat every single birthing person as if they might sue the pants off of you if you mess it up.
Yeah.
Because that's
Yeah.
basically what that was the message to me from those practitioners. They're like, uh-oh, we better make sure this person has proper informed consent for the first time maybe in their careers. I should say that if they listen, they're not going to listen to this podcast maybe, but if they do, they're going to be like, was she talking about me? Yeah, for the first time ever, they're like really making sure that the person is making a choice based on having all the information and feeling good about what they're saying yes to. And they understand the risks by saying yes to this. It was like night and day from how I've seen other births go, where it really is just trying to talk someone into one direction of how the medical team wants it to go. And they
Mhm.
don't have guaranteed results, by the way. If they did, well, hallelujah, let's take those good good advice and those guaranteed results. But we know that in obstetrics, things can go many, many, many different ways. So, one of the worst documents that exists in our profession, I think, is when someone turns down an induction that is being offered by the medical team. A person will be given a document. You could be 41 weeks pregnant, super hormonal, the height of your pregnancy, you're exhausted, your brain is shrunk, and you're given a document that says, I understand that by turning down the medical advice of the doctors, I put myself and my baby at risk of death. Sign here.
Whoa.
Whoa, right? And the
Yeah.
honest truth is, they could give that same form to consent for induction. I understand that by consenting to be induced, I put myself and my baby at an elevated risk of death. That's the absolute truth as well. It's not a humongously huge risk, but neither is it true to stay 41 weeks pregnant with no other reasons to induce. If you're
Mm,
only 41 weeks pregnant and nothing else is showing any other reason, no indications, the same is true for an induction. But
mm,
why don't they give us that paper in the other case? Because they don't want to talk us out of the thing they're trying to talk us into. When the
yeah.
truth is, if I'm pregnant and it's my baby in my body, I am assuming all the risk. Of course I am. It's always going to be my risk, whether I'm a malpractice lawyer or not. I'm always assuming all the risks for my body. The second I get pregnant, it's a risk to my body. I'm altering my body, right? There's no guarantees in life, except
Mm,
one. We all end in the same place, by the
yeah.
way, right?
Yeah.
The one thing we try and avoid for our whole life is the one thing that's guaranteed. So, to me, that's a huge insult when people in labor are given, or before their labor starts, is given that document, because of course I've assumed the risk. Of course, all the
Mm,
risk is mine. No matter whether I take your advice or my advice, if it leads to an adverse outcome, of course it's going to be my own brain that's always going to be thinking back, how could I have made things go differently? I think
mm,
that's a cruel and unusual document that we give to people, and it shows me specifically, I think, how we don't treat laboring people like consenting adults who can make their own choices, because we're manipulating them to take one way or the other.
mhm. And instilling fear from the get-go, essentially.
Yeah, essentially. And by the way, if you're 41 weeks pregnant and you're trying to get your labor to start, you need oxytocin flowing, which is the hormone that's released from our brains when we're feeling trust and confidence and love. So
Mhm.
take away all my trust and confidence and love, raise my cortisol levels, and then I have less oxytocin than I started with. So it's like, well, if you can get your labor started on your own tonight, great. Well, you just put all these new anxious fears into me. Like, where's my oxytocin going? Of course it's out the window, right?
Yeah.
Like
Yeah.
it's a losing battle. It really is in some cases. And really, I was 42 weeks pregnant and I was heavily pressured to induce, and I did not get induced. Although 10 years later, when I became a doula and I remembered back, huh, I did get a stretch and sweep that day when I went for the OB consult. They did not tell me. So
Mm,
if someone's going to say, oh, does it really happen where things get done without consent? 100% it was done to me. I would
Mm-hmm.
consent to a stretch and sweep. I didn't even know what it was. It was only after when I became a doula and I thought back on all of the symptoms after I had a consult with an OB, which is my only one consult with an OB, who really wanted to induce me that day, told me basically that I wasted her time showing up for a consult and not wanting to be induced. And then did a procedure without my knowledge, without my consent. I cried in the bathroom afterwards. I bled. I was confused, and it put a lot of fear into me, and
Mm,
it's still happening today. It's still happening a lot. And I wish that it wasn't happening, but even when a doula is in the room, it's happening. So
mm,
imagine when you don't have this extra person in the room witnessing. And I don't even care if a doula doesn't want to say that they're advocating, but even just being in the room, you're witnessing, right? I've witnessed Pitocin being administered to a person without their knowledge. And the nurse, when we called her out on it to ask, hey, excuse me, what is this? I don't even know when the IV went in. Honestly, I was like, hey, you're getting an IV. When did this happen? I think I went to the bathroom once for a minute. I'm like, hey, what's going on here? Oh, well, the doctor knows what I'm doing. It came from the doctor's orders. And I turned to the client. Did you know that medication's being administered? No, I did not. So, I
mm,
mean, we're awake, we're conscious. This person was able to have a conversation. Why didn't we have that conversation? Right?
mhm,
I don't
mhm.
I don't really know why we're awake and not being given all these choices, right? So I wish that I could say, hey, things are getting better, but I'm not sure. It's a hit and miss, right? I think we
Yeah.
still need, as birthing people, I think we still need to be aware for ourselves what we want and that it's valid. And sometimes it might not be possible, right? I want to birth in the forest. Okay, maybe not, right? I want to birth in the water. Maybe there's an indication that, doesn't let you safely birth in the water. It doesn't mean that you can't ask the questions, well, why not? Well, just because you never do it, why can't we do it now?
Mm,
Right? Can we give it a
mhm.
go? That's my favorite line. Can we give it a go? Give it a shot.
Let's just give it a shot.
Give it a shot. There was a
Yeah.
there was a midwife at a recent birth. I'd like to do a cervical exam. Lie down, put your legs back, need to be able to see. And the person was, experiencing labor without an epidural. So it was not comfortable to be lying down. They were upright and breathing and leaning, and they wanted the cervical check. They did want to see where is their body at. They did not want to lie down. So I asked the midwife, are you able to check from this standing up position? Well, no, I'm not really used to it. I'm not sure about the angle. Well, can you give it a go? I mean, if you've never done it and you're never going to do it, you're never going to know what that angle feels like. You're never going to know
Mhm.
can you reach it.
Yeah.
Go. The person doesn't want to lie down, has consented to you trying it from this angle. Wouldn't that be great if you could access what the information you need without altering somebody's birth wishes? That's a touch too. Lie down is a touch. When
Mm,
someone arrives at triage and they need to put those bands on, lie down for 30 minutes so that we can get a clear tracing for 30 minutes. You're in active labor, and now you have to lie down still for 30 minutes. That's a touch.
mhm,
That's a
mhm.
touch that's going to potentially lead that person to want an epidural. Whereas if they were upright, if someone could put those bands on and they can stay in an upright position, they might be able to get further along without it.
Yeah. A friend of mine, when she was in labor in the hospital, because she wanted to be able to move around and she didn't have an epidural, a nurse had to be beside her on the floor the whole time, holding the monitor. And so it's definitely not easier when women have the mobility to move around the way that their body wants to move. And so let's talk a little bit about the hospital room and the bed. Um, the reclining position is much easier and simpler for someone to check you, to inspect, to examine, to get in there, to do whatever they feel is necessary to do. Um, and it's much easier to be in that position if you do have an epidural, because if you don't have an epidural, your body, for the most part, wants to move in different positions, wants to respond to the signaling from your baby and what feels comfortable and right for you in that moment, that you're getting these like primal impulses to do, to move, to vocalize, to bear down when you feel like your body wants to bear down. um, and so the way that the hospital room is structured, I'd love for you to elaborate on this, but it is very much centered on, the cascade of interventions that happen.
Absolutely. It's centered on, can we get all our equipment to be in a place where it's readily accessible in a case of an emergency? Because that's the other thing about hospitals, right? We're treating everybody as if they potentially might need an emergency intervention, right? So is everything set up in a way so the bed is in the middle of the room? There's an IV post that can fit on either side of the bed, and then there's the nursing computer station, and then there's lights above that computer station, lights above the patient where they're sitting. There might be a window with some lights and spacing. And then there's the baby warming station. So when your baby gets checked out, or if there's any respiratory concerns right at the moment of birth, they'll whisk the baby to the side warmer. Side warmer is on the other side of the room, so it's not really close enough to the bed. And partly that's because they need space around the bed in case they need to intervene before the baby's born with the maternal body. Is there enough space to be maneuvering at the bed? The bed itself, if you go to any website that sells hospital labor birthing beds, it will show you all their wonderful benefits and features for laboring people. And most of it, shockingly, the parts that get to what's actually good for the birthing body are near the end. The first ones are all about the view for the doctors and, you know, the stirrups that get the leg up. And then there's lights from the ceiling that beam down exactly where the open legs are on the bed. The bottom part of the bed completely comes away. So once a person's legs go up in those stirrups, they take away the bottom part of the bed. The doctor can saddle right up on their stool and get a really good view, turn on those lights from the top, and here's my surgical tray right next to me, and everything is just boop, 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 perfectly set up for the person who's attending and actively managing that labor. The parts of the bed on that description near the bottom where it's like, for the birthing person, we can use this bed. I've never seen it used that way. It shows all these maneuvers where you can take away the bottom part of the bed when you're not in it. So you could be standing at the end of the bed and using those handrails for like gripping and reclining like this, or having the partner go into the back of the bed. Can you imagine? So there's the bed that reclines on the back. So the backrest goes up and down. Then you've got the middle part that stays stationary, and then the third part of the bed can go away. So now imagine partners sitting in that seat part, legs spread, and supporting the pregnant person under their arms, because the bottom part of the bed doesn't exist to make room for her body. I've never seen the bed used like that. Ever, 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 ever. And even the fact that, you know, like, it's got the handrails, right? Like any other hospital bed, in case someone's a fall risk, we can put up that handrail so they don't roll over. On the inside, you have buttons so that your reclining can go up and down. But on the outside of the bed, there are more buttons that can go up and down. The entire bed can raise up and down. So even that, it's like, it's taking the control out of the person who's in the bed. If the bed is really high and you can't even jump down to go to the bathroom because it's been raised up so that your provider can do something and see something. So the bed might be really, really high. You can't actually get down until the bed is lower, but you can't lower the bed yourself because you don't see where the buttons are. So it's really designed, in my opinion, to restrict our movements, to have us be in that lithotomy position, because it's what all of the providers seem to prefer to be able to do their part of their job. But it's not at all conducive to how does labor feel and will it make you feel better? And maybe in theory, those beds are designed with some practicality for the birthing person, but we never use it that way. I never see them used in a way that someone's like trapezing from it, you know, they're not using it as dangling. Even a simple tool like a birth bar, it's this horseshoe shaped bar that can stick into halfway through the bed. It's available in most of the rooms, and it's just gathering dust if you don't have a doula that says, hey, how about we try the birth bar and get to dangle and do throne positions. Throne position is where you're basically scooched up to the top of the bed, and then you might be pulling down, so you're kind of on the bed, but still in a squatty potty pulling down motion. It's a fine position to birth in bed, but again, a provider will not be able to do a cervical exam very well in that position. They won't be able to assist with their fingers or to watch the baby emerge. But then you have to ask yourself, is that part of your plan? Is it important for you to have the provider watch every part of the baby being born, right? to the point too of the bed being taken away, once someone's legs are in stirrup and the bed is taken away, if that's the case, that means you're pushing in the same position for the entire time. You don't really have an opportunity even to turn to your side if the bed has completely been taken away. Um, so that's one
Mm,
of the considerations for if you even want to be in the bed, really. Do you even
yeah.
want to be birthing in that bed in the typical way? And then with the side warmer, it's my desire that that side warmer can somehow be closer, maybe, or can the equipment be on a dolly? You know, they have ultrasound equipment that can come in on a wheeled dolly device. Well, you know, in the moment when the baby is born and it's put on the person's chest, perhaps skin to skin, just making that suggestion. Baby's on your skin and you're having that first moment. And I also think that the birthing person should do their own body touching of their baby and rubbing and resuscitating. We want to know
Hmm.
that the baby is breathing. That is important. They don't use their lungs in utero. It's only once their body is out that they start to use their lungs. So time is of the essence, but there's no reason to think that the gloved hands of your medical professionals is better for getting that baby to start breathing than a person's own hands doing it. But let's say that baby doesn't breathe in the first 60 seconds. That's an indication to clamp the cord, cut real quick, and whisk that baby over to the side warmer so that they can assist with an air little puff of air to get the baby breathing on their own. Now, nobody wants their baby not breathing. They want their baby resuscitated if that help is necessary. But why can't we have that equipment ready to go on a dolly so that that baby on my chest is just flipped upside down, back against me, and now you're doing the resuscitation, the little puff of air, or the, you know, sometimes there's suctioning. Why can't the equipment be close enough that you can just do that from the mother's chest? So I'm
Hmm.
continuing to get skin to skin. The baby just left the only home they ever knew. And now
Yeah.
they're emerging into this brand new, very different space, and then
Mhm.
whisked away with gloved hands to a side station, leaving the mother to be anxious, the baby to be anxious, the partner probably scared and confused. And that's
Mhm.
really a product of the setup of the room being, again, designed for the practitioners to be able to maneuver around the stations, around the people, around each other, right? In a critical time too, when the baby is being born, especially if they already are anticipating respiratory issues. You might have at the final moment of your baby being born, you might have two nurses in the room, your staff obstetrician, they likely will have a student or a resident with them. Perhaps there's a respiratory specialist or a pediatric specialist just in case. So that's already 6 people outside of your partner and maybe your doula who's there as well. So now suddenly this has turned into a chaotic environment where you're like, oh my God, who are all these practitioners? We must be seriously in trouble to need all of this medical help in this moment. And so the space is designed to have room for all of these bodies to not be able to like knock shoulders and elbows with each other. It's really
Mm.
not that me as the person birthing wants a room that's this size and for my baby to be whisked so far away from me in that critical time when I'm not even sure what's happening. So
Yeah.
the rooms are not amazing, in my opinion, not amazing. The lights can be dimmed if you play with them,
That's nice.
right? If you play
It is. Yeah.
not always. Some of the hospitals have started to put little like fairy lights around the nursing station area so that they can have enough illumination for their charting and what they need to do, but they don't
Okay.
have to turn on all the lights in the room, right?
Okay.
But when it
Yeah.
comes to the point of pushing too, as soon as someone's lying on the bed, the doctors need to see, so they turn on these very, very bright lights. And for sure, afterwards, when you're, you know, if someone needs repair on their vulva, you definitely want bright lights. So I'm not
Yeah.
saying let's change all the light bulbs, but for the moment of laboring and birthing, the dim, you know, not having lights dimmed can be definitely an impact. So I consider that a touch too. If your birth room
Mm.
those lights won't turn off or you can't figure it out, that's an impact. That's a touch, right?
Yeah. Yeah.
If you can't maneuver the bed in such a way to get comfortable, honestly, sometimes because they have those 3 levels of the bed, sometimes that last part doesn't come up high enough. Have you ever tried to sleep with your legs are just a little bit lower? It's a terrible feeling. Like
Hmm.
your
Yeah.
legs elevated, you know, or
Yeah.
at least to be at the same level. Like those beds are not amazing. Not amazing.
Right.
So
Yeah.
whenever it's like, oh, it's best to birth in the hospital, we better be in the hospital where this is especially designed for birth. It's really not especially designed for how some people's birth wishes are, right?
Mm,
My birth wish is to be relatively untouched and just let my body do its thing. And I want to just, avoid an epidural and have a smooth, low intervention birth. Why am I choosing a high risk hospital?
yeah.
Why am I choosing a hospital at all?
Mm, yeah.
People
And
birthing at a high risk hospital downtown in Toronto. I like birthing there too. I like the staff. I like being there. However, it's not necessarily the place for low intervention birth. If
right.
somebody says to me early on in their, when I interview people and they're, 15 weeks pregnant and they say, well, I want like a really low intervention birth, but I've booked an OB at the highest risk hospital in the city. My question is, well, why? What are we expecting to get from the hospital that's going to actually help us to get the birth we think we want going into it, right?
Hmm.
And
Hmm.
then we're shocked when we get the whole medical cascade happen. Well, that's what they're good at doing.
Yeah.
Want to say that that's a bad thing. I want our high risk hospitals to be really good at the interventions and the medical things that they do. I want them to be really good at it. But I would really love for us to take more of the low risk birth out of the hospitals so that the hospital can do a really great job with the percentage of people who actually need that high uh, high active management kind of birth. Anyone who
Hmm.
doesn't need that, why are we putting them in that arena?
Yeah. There is research showing that if even if just you plan for laboring and potentially birthing at home or a birthing center, that results in better outcomes for mom and baby,
That's right.
or more so for mom. And so just having that plan and moving towards that has better outcomes. So then your question is so valid, like for those low risk pregnancies and those cases, like why are we going into the hospital system when we know that research shows that there's more likely um, going to be interventions involved in that?
Sometimes it's because of a shortage of midwives, and it's only our midwives in Ontario, registered midwives, who are attending birth at home. Um, so part of it is, did you have a low risk pregnancy? Did you try and get a midwife and they didn't have space for you? We definitely have a shortage of midwives. There are more
Mm,
people wishing to have a midwife than who are having a midwife. Now, midwives also mostly birth in hospital as well. They're not primarily home birth practitioners. But so right off the bat, we don't have enough people helping us to feel safe at home, right?
mm,
You can have a
mhm,
home birth and be free birthing or birth with another attendant. It's not necessarily recommended, and most people won't feel safe doing that, right? So if you
mhm,
wanted to have an actual certified registered professional, it would be a midwife. So do you actually have access to one is number one. And then from the other part of it is, again, we have to be safe where we're giving birth. I need to be in an environment where I feel like I've made the safe choice. Am I being witnessed by people who can, do life-saving interventions if I should need it, right?
mhm,
Midwives are trained to do that as well. They are trained in low intervention birth, but they are also trained in resuscitating babies and helping in those complicated kind of things. They don't take high risk birth in the first place. So it's not like they're taking unsafe measures. The perception out there, in my experience from talking to people, because I talk to lots and lots of people about this, is that a lot of people actually don't even realize, first of all, that midwives are registered, that they're paid by OHIP, that there's a whole process of monitoring their role as well, that they work in conjunction with the hospitals as a medical team, that that's a safe and viable option. For a lot of people, they think the best is the hospital, the best is the doctor, and that's the best for everything. And really,
mhm,
they're not, your obstetrician is a surgeon. They are the best at surgery. They are the
mhm,
best at forceps. They are the best at vacuum extraction. They are the best at episiotomies because they are the ones who are trained and are doing that a lot. If you
mhm.
want those things, or you think you probably will need those things, you should go with a surgeon so that you have a practitioner who can do the things you want. Most of
Yeah.
us don't go into labor wanting forceps and wanting all of those other interventions, but we go to a person whose specialty is doing those things. So it tends to be that we have a perception that it's safer to be in hospital. And by the way, often it's the partner who feels safer in hospital. So maybe the pregnant person might want to be out of hospital, But for the first one, we don't know what to expect. So we better have the first one in the hospital just in case. But if you have the first one in hospital, high chance you're going to have all of them in hospital, because you're right about the low intervention rate. Even if you just plan for a home birth, doesn't mean you stick with it and birthed at home.
Hmm.
You can still change your mind and move to the hospital and get an epidural and whatever you want. You can change your mind, but even just planning for a home birth puts you in a rate of 5% cesarean. So 5% of people who plan a home birth will end up in a cesarean. And partly that's because only low risk people are planning for home birth, right? So anyone who already has a higher chance of a cesarean is not planning for it. But at the
Hmm.
other hand, every person who comes into the hospital is at a higher risk of having a cesarean. At Mount Sinai, the rate of cesarean is, I think, 32% of people
Hmm.
birthing will have a cesarean. At St. Joe's, which is around the corner from me, it's 34%, and they're
Hmm.
not a high risk hospital. So even just starting your birth at the hospital, you're 34% chance of having a cesarean. And I think it's because of all of the available things, how easy it is to say yes to that epidural and that cascade. But when you're at home, even at home, people are like, yeah, I should have maybe done something differently, but you're more likely to follow through and finish the job at home, because most of the time we're still vaginally birthing. Most of the time.
Hmm.
We only
Hmm.
think of that stat as like on the side of, oh, that's a lot of cesarean. It's still way more vaginal birth, right? But we're not
Yeah.
really gearing it towards that.
Yeah.
By the way, if anybody's interested, these stats were from 2020. U of T obstetrics department put them out. And the lowest cesarean rate in the city is at Sunnybrook at 18%. And I would really like for the rest of the hospitals to start figuring out what is the difference, because Sunnybrook is also one of our high risk hospitals, and they are just showing a vastly different statistic for cesarean birth.
Mm.
That feels a little more aligned with how many births medically really should end in a safe cesarean rather than a risky vaginal birth. Vaginal
Hmm.
birth is not safer for everybody.
Hmm. Have you attended births at Sunnybrook? Do you see anything
Not as
different going on?
frequently, not as frequently as the downtown hospitals, so not enough
Mhm.
for me to really judge. But I know that they are working towards their baby friendly initiative. I don't know if that has something to do with it.
Right.
Maybe it's the way their nursing team has been, the professional development that they do. I'm not really sure what exactly the difference is. It could even be timelines. Sometimes it's the threshold of timelines. Some
Mm.
hospitals have it like, from the time your membranes are ruptured, we'd like to see a baby born within 12 or 18 hours. In
Mm.
other hospitals, it might be, we want to see the baby born within 36 hours. So the
Mhm.
difference of, at 12 hours, did you have the baby? No, we better have a cesarean, rather than let's wait and see a little bit longer. And again, wait and see, it's not like take a dangerous risk. It's more like, if we're monitoring a person and the baby's heart rate is fine and healthy and the gestational person is fine and healthy, let's continue laboring, right? As
Mhm.
opposed to having the assessment of, well, it's been X amount of hours and you're only this far along, and we're afraid that if we keep going, that you'll get tired, or baby will get tired, and the uterus gets tired, and all these
Mhm.
baby maybes, right? So sometimes it's failure to wait,
I
right?
see. Yeah.
Sometimes it's just failure to wait. We just
Yeah.
don't have the time anymore, Dr. Cindy. And again, like COVID times has given us a nursing shortage, right?
Oh,
So
right.
if you
Yes.
need one-to-one nurse, if you need
Mm.
one-to-one nurse for birthing person, a spontaneous labor, that could go on and on and on. But if we break your water right from the door, we know that that's an 18-hour limit or a 24-hour limit. So we kind of already have an end time to it. If your baby doesn't
Mm.
come out on its own, we're going to end it in a cesarean, no problem. And then at least we know at the next shift cycle, the new nurse is in with a new client, right?
Yeah. Yeah.
And we don't want waiting times. I've had people wait for the start of induction in the waiting room up to 8 hours waiting just to start an induction.
Mhm.
So, again, we're not told that when the doctor says, we don't want you to go past 39 weeks. I'm not going to allow it. I won't allow it to go past 39 weeks. That to me is not the language of consent, by the way. But then you get to
Right.
that 39-week point and you're thinking to yourself, like, oh my gosh, it's not safe for me to be pregnant, not even for one more day. Then you spend one day waiting in the waiting room. You spend 2 days
Mhm.
trying to get your labor started, and then like another day of active labor. 4 days later, you're like, well, if I had waited 4 more days, maybe my labor would have spontaneously started.
Mhm. Yeah.
I don't know.
Yeah.
So
Yeah. I had Dr. Sarah Buckley on the podcast who was saying we don't even fully understand what starts labor. And yet we're muddling around with all of these ways to induce labor. And she's like, we're like overstepping because we don't even fully understand what starts labor in the first place, right? Sure, like we understand that there are some hormones involved, but there's like aspects from coming from the baby that we don't fully understand. And there's melatonin involved that we don't completely understand. So there's all of these different pathways and hormonal cascades that are taking place that we don't really have a grasp on, and yet we're poking and prodding and doing all of these different things.
that's right.
Um, if you're okay, I'd like to, because you mentioned the language that we're using, I'd like to just kind of talk a little bit about that because when someone is at the end of their pregnancy, maybe labor has started and the hormones are all primed for that birth to take place. We're super vulnerable as the birthing person. Um, and we touched a little bit upon like the facial expressions of the practitioners, maybe some benign questions that might be taken a certain way by the birthing person. But let's delve a little bit deeper into the language and how we can maybe shift things that would um, actually have an impact on the birth experience in some way.
Mhm. For me, it even starts with the word delivery. Like, what are we delivering? Right?
I've
Like,
heard this a lot from people in the birth world.
is it a
Yeah.
stork? Is it the stork flying over with the bundle? They're dropping off the baby bundle. Oh, here's your delivery.
Yeah.
It's not pizza. The closest I can get to finding it is if you go to the origin of the College of Physicians and Surgeons, when they really started to gain momentum as a group and gain power to be able to shut out other modalities of healthcare, there kind of came this whole language around it that's special to them, right? So delivery in an old sense, and if you think back to like when that was, right, turn of the 20th century, right, the formation of it, we shall deliver thee from harm, right? That's
Mm,
the closest I can get is it's deliverance. The
mm,
doctors are providing deliverance to birthing people. So it's already coming from a paradigm of this is a dangerous event that you need saving from. So here's the almighty doctor who's going to deliver your baby from harm, right? So it's
mm,
already assuming that your body is a dangerous scenario. This is putting you at huge risk, and you better have these medical professionals witnessing and guiding and telling you how to birth. We never used to birth on our backs. If you look at any ancient symbols of fertility, of people birthing, Mayan statues with yones open like this, they're squatting, they're standing. I was in Hawaii where the sacred stones of the old monarch used to birth. They didn't have reclined positions. These are all stones where people were dangling and upright positions. We only started to lie down when we were being delivered, right?
mm,
So when we started to be delivered, and even now when I speak to parents in the class on the first day, I kind of cut apart some of the terminology and I say, when I say birth, I mean delivery, but I don't say delivery because it doesn't make sense to me, right?
mm,
If someone says to you, who's going to deliver your baby? Automatically, it's like it better be a professional. But if I ask someone, who's going to catch your baby? Then suddenly that could be you catching your own baby. It could be your partner catching the baby. Catching is like, well, yeah, I've caught things before. The baby actually emerging, if all goes to plan, which most of the time it will go to plan if we touch less, the baby's just emerging and let's not let it hit the ground, right? You don't
yeah.
want your baby bouncing off the floor. So someone's got to catch the baby. Is it the midwife catching? Is it your doctor catching? Do you want to catch? Does partner want to catch? It really makes it already like, oh, wow, so that's not always going to have to be a doctor's role. But when you say delivery, then it's like, oh, well, I'm not qualified to deliver a baby. I don't even know what that means. I think it's
Mhm,
purpose. I think some of the words are done on purpose. Another one that I think is an interesting, I'll say a bit of trickery, is that you never hear the word Pitocin in the hospital, or Certitocin, I think is the new one. Those are brand names, right? So once the the argument from the nurse was, well, we don't call it by the brand name. We just call it oxytocin. But
Yeah.
when you're told in labor, hey, we'd like to give you a little bit of oxytocin to keep your labor going, you might think, oh, that's just what I get. That's what I need. That's the stuff my brain produces. But no, that's not the same oxytocin that's coming through an IV. It's kind of this, oh, it's the same thing. Don't worry. Well, it's not the same thing. It's medicine, right? And it's
Hmm.
impacting me differently than my own release of oxytocin would
Yeah.
do from my brain. Same thing, like we don't call saline water. We don't say, hey, we want to give you some hydration. It's just like water. We just say, hey, it's saline. So
Hmm.
why are we not calling a synthetic oxytocin? I think it's because if someone's offered, hey, we'd like to give you some synthetic oxytocin to augment your labor, you might go, oh, wait a second. Do I need that? Do I want that? That's artificial, right? That's something that's coming through an IV. Then you want to ask more questions. But when someone says, hey, we're just going to give you a little oxytocin, it sounds like, oh, that sounds easy and natural, right?
Hmm.
I think
Hmm.
the language matters, and I think it matters to the practitioners too. I don't think it's by accident. I don't think
Mm.
it's by accident that every practitioner in the actual hospital will say oxytocin all the time. And I am that cheeky doula who has asked a couple of nurses, are you allowed to say oxytocin? I got no answer. When I asked that question, I got no answer. I just got some eyebrows. I can't help but wonder. Again, I'm not in those nurses' rounds, but I can't help but wonder, is it an accident? Is it? I don't think so. I think it's very purposeful. So if the language from the medical side of the world is very purposeful, we need to also understand that language and then create the language that's empowering for ourselves, right?
Hmm.
Hypnobirthing has done that. The modality of hypnobirthing as a method of childbirth and preparation for childbirth has reorganized a lot of the terminology, right? So instead of saying contractions, let's say surges, because that's, a little more visual for what's happening, right?
Mm.
Maybe that doesn't make a difference for people, and maybe it does, right? Even
Hmm.
saying pain in labor, the more we say pain to a person, the more they're expecting pain, the more they're exacerbating their pain.
Yeah. Yeah.
I've heard, I had heard a nurse once say with such inflection too, how much pain are you in? I need to chart the level of pain. And it was an induction. So, the person said, well, 3. We're going to need to see a lot more pain before it's actually impactful. And I'm just thinking, oh my goodness, like if you're telling someone that they have to have pain in order to have surgical dilation and in order to have cervical change, that's already setting us up for, gee, I don't even know. Like that's not going to be bearable. Like
No.
why are we creating more of what we don't want to see? Why
Yeah.
are we
Yeah.
creating comfort? How can I make you more comfortable? Are you uncomfortable
Mm.
by that sensation? Like we don't have to not talk about contractions, but at the same time, why are we making it go a certain way, right?
Hmm. Hmm.
I think it matters.
I think so too, because especially in that state where you're so vulnerable and it's like you're less in your intellect, you're supposed to be anyways more in your body because of all the hormones and just like the process of birth itself. You're so susceptible to the language coming in, the facial expressions, and because you're in your primal brain, like these people coming in who are medical professionals who are sure there to help you and they're very well trained, they're still strangers, right? And so like who they are and like what they bring to the birth room definitely has an impact on your experience. um, and Barbara Harper, who was on the podcast as well, I'm sure you know her.
I
uh,
should do.
yeah, yeah, she's wonderful, and she was saying how no one should ever ask the person who's in labor if they're having pain. Ask them, can I make some, like what you said, is there something I can do to make you more comfortable? And everyone should speak in hushed tones.
Yes. Yes.
And I'm sure you never see that.
Oh, this is why I do really appreciate if someone can have a doula because we help to mimic the kind of atmosphere a person wants to create. So even if someone comes in loud, we're already going hushed voices to implement,
Mm.
right? And using the language of exactly why would I ask you if you're in pain? How's your pain? How can I make you more comfortable? Or, like I also don't want to diminish somebody's experience, right? That was very intense. How did that feel? Was that different? Can we try a new position? Do you want to go in the water? Now that you've said Barbara Harper, her famous line is just add water.
Yeah.
Um, but yeah, like, how can I add to your comfort? Was it helpful
Mhm.
what I was doing? Did that ease the sensation you were experiencing? It makes a difference to have it be like, we can be more comfortable in labor rather than, gee, I know that hurts, sorry, right?
Yeah, yeah.
And that's the other
There's
thing
nothing.
I've incorporated into my class to make sure people know that in any other medical field, I think in dentistry, if you were at the dentist and someone's got their fingers in your mouth and you go, ow, 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 they're going to stop what they're doing and they're going to ask you, oh, what happened? Can I make you more comfortable? What hurt? In
Mm,
obstetrics, fingers are in your vagina. Ow, 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 that hurts. Oh, I know, honey, sorry. And they keep going. Or the fundal pressure, they do checks after the baby's born, so they're pressing on the fundus. Ow, 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 I don't like that. Oh, I know, I'm sorry, I have to do it.
mhm.
No other medical field from what I've witnessed and experienced. I go to my dermatologist, they start doing something, ow, ow, ow. They're not going to be like, oh, yeah, grin and bear it. That's just how it goes. You know,
Yeah, yeah.
like,
It's
why
so
can't
peculiar.
Yeah, why can't we treat it the same way where someone goes, ow, ow, oh, let me see if I can go slower. There is
Mm,
some discomfort. How about I try again? How about now? Or
mm,
what's the alternative? Well, we don't have to do that if it's very painful. And to the point again, like, is it easier when someone's on an epidural? There's no more ow, ow, ow. And then
yeah,
the practitioner can really get up there. Let me really see how high the baby is. Let me see if I can manually turn that baby for you. Like, you can get a lot more invasive into a person's body if they're being frozen, right? It's
mhm,
harder
mhm.
to ignore their ow, ow, ow. So I do have that in my class where I say, I'm sorry, but you should probably find ways to say no and stop, which is not easy for people when they're in that vulnerable state, when they're in a state of like, I have to surrender to the feelings of my body and I want to trust my practitioner, but then I'm feeling this danger pain and I want to say stop and no and don't do it, but I can't really muster the words.
Yeah,
And maybe it's part of our culture too, where we're polite, right?
mhm,
Oh, I don't know if I like that. Can we do something? Like this kind of hushed tones. This is again where I think partners are really their role is so important, right? As the person who's not in labor, you might still be also in a very vulnerable state, but your partner's little cues. If they're saying, I'm not sure, do you know that when she says, I'm not sure, that actually is a no for her, that she can't
mm,
assertively say? Maybe it's up to partner to say, can you stop? She said, ow,
yeah,
pause. It might be a pause. It might not be, don't do what you're doing, right?
mhm,
Stop, tell us what you're doing. Why does that hurt? Is there another way to do it? You know,
mm,
but again, we kind of give ourselves to the authority of the medical world. Well, they know what they're doing, so that must be the only way.
yeah. Can you talk a little bit about how you've kind of changed the structure of your prenatal class a little bit to accommodate for what you're seeing, for what sounds like you're seeing quite frequently in the hospitals?
Yeah, my class used to be a little bit less focused on all the potential ways that you have to assert yourself. It was a little more like, okay, here's how we do it. Here's how you manage at home. Here's how you stay home as long as possible. Strategies for early labor and coping and techniques. And that's all still in there. And it also in my opinion, a childbirth class today requires a full view of what happens or could happen once you're in the hospital scene. Even for someone who's planning an out of hospital experience, we don't know if you're going to have a reason to transfer care into hospital. And if we are listening to the results of birth trauma, people are reporting after the fact, after they've had their baby, a high number of birth trauma stories, right? And that's individual. It's not to say that if somebody has one, two, three happen at their birth, ergo that leads to trauma. It really is about how a person is experiencing the choices that they made throughout their labor. And it's occurred to me as I've been teaching the class for 10 years, I've had to make a shift where there's a lot more details about what can happen in the hospital. Here's what a surgical room looks like when someone's giving birth. Here's what forceps look like. Here's what a vacuum looks like. Here's what even the Foley catheter looks like. This is the cascade of interventions that possibly could happen, right? It's just not realistic for people to not have the full view of what they're saying no to. you
Mhm,
know and I've seen that in some of the classes where it's a lot of preparation for how to do the labor without interventions, which I think is very important and very valid. And I definitely have that in the class too. But if we skip that hospital part because we assume that people are not going that way, or they don't want to know that part, or they don't need to know that part, it's actually not necessarily enough of a buy-in for them to avoid those things, or for the
Mm.
partners to know, why are we avoiding those things? I had someone recently ask me if the epidural, they said, doesn't the epidural make it easier to give birth? I thought that's why we do it for everybody. And I said, not necessarily. The purpose of the epidural is to numb the pain of the contractions, that you're not feeling the body sensations while the body is still laboring. It's definitely impeded because of position movement and limiting food, and when it comes to pushing, to not have the natural urge, or the body's own sensation to push definitely impacts. I wouldn't say it makes it easier to birth on an epidural, even though some people wouldn't really comfortably be able to get to the end of their labor without an epidural. So yes, we do use that tool sometimes, but it's not because it makes it easier. You
Mm.
know, like that perception of, oh, we're doing all these things because birth happens faster this way, or easier, or better. It's just not actually true, right? So I think in my class, I've modified it to be, hey, here's all the things that I know we don't want right now, but if it should be offered to you, this is what it looks like. And this is what the alternative could be. And sometimes this goes in this direction, and it doesn't always go in that direction. But when you know what you're getting into when you say yes to that induction, it really makes it more real. Do I actually want this induction? Do I need this induction? Or whatever it is, whatever the intervention is. Once you've already seen it, okay, well, I might not want it, but if I also don't want the alternative, so let's go for it, right?
Mhm. Yeah, yeah. Such valuable information, and for people not to go into that experience blind, especially for someone whose birth plan is like a natural birth plan. I don't want any interventions. I want skin to skin. I want to breastfeed afterwards. I don't want anyone to touch me. And if things don't go that way for whatever reason, then that could be the source of the trauma, the unexpectedness,
That's right.
right? And not knowing and feeling so vulnerable and out of control. That could
That's
be
right.
where the trauma stems from.
I wish
Yeah.
I had known what it would look like. I had no idea.
Mhm.
And then when the moment of it, I was so shocked. And, you know, even the fentanyl part, like honestly, I had no idea fentanyl was in it until it was already in my back and I was looking at the little cassette disc. Even
Yeah.
that could have somebody feel a certain way later on. And by later on, it could be 10 years later or 20 years later. We relive our birth experiences over and over and over again, right?
Mhm.
Questioning each part, right?
Yeah.
Especially as new research comes out. Oh, I guess I should have said no to that. That's how we
Mhm.
know that our medical model is not perfect,
Mm.
because research comes out to change what we used to be doing, and now we're doing a different way. And I know, like, when we know better, we do better. But why are we just assuming that all of the old practices were automatically so terrible and so bad? Birthing upright was so dangerous. Now, thank goodness, the doctor can see to deliver my baby from harm. I mean,
Mm.
I don't
Yep.
know. I don't know. Is that true? Is
Yeah.
it? I'm not saying let's go back to a time where nobody has access to hospitals, or, you know, I think we do need access to epidural. I don't
Mm.
think that it's right that I had to transfer care from my midwife to get the epidural. We don't do that anymore. Registered midwives can attend a birth. A person can get an epidural and they still are attended by their midwife. I think that should be the case. You shouldn't have to choose between your midwife and an epidural. On the other hand, it makes it a lot more favorable for someone to just take all of the interventions. There's not as much encouragement necessarily from the midwives to keep a person off an epidural either, right? Which is not their job to. But if someone's going for a certain birth, they want a midwife because they're looking for that low intervention birth, they might be expecting the midwife will give them some tools and skills and help to avoid those medical things. And that's not necessarily happening when they're able to attend both kinds of birth.
Mm. Yeah. Yeah, I think people do need to hear the message that things are always changing, the policies are always changing, and what is the gold standard now might not be the gold standard in 5 or 10 years, and that what happens in the research takes quite a bit of time to trickle into practice, like 20 years sometimes, right?
That's
And
right.
so what we're finding and discovering and researching is actually more beneficial for the birthing person and baby might not actually go into practice and for another 20 years. So just for people to understand that that's just sort of the reality of the medical system right now.
And there's lots of ways that birth can go. And if somebody wants to take that route and say, I trust my doctors and I'm just going to let them do what they believe is medically necessary and I want to take that path, that's fine. There's lots of different ways that this can happen, right? There's
Hmm.
around the world thousands of ways that people give birth. That just should go to show that you as an individual have an individual scenario that's unique in some ways. In one aspect, we're all doing this thing for millennia, right? Like it's in our cells to be giving birth. That's why we're still here, that everyone's
Yeah.
reproducing. On the other hand, you're still an individual body, so you get to decide, does that protocol or policy or stand or gold standard apply to me? When it comes
Hmm.
to menstruation, we're really clear that everyone menstruates on a different cycle. They
Mm.
might have a different amount of time in between, a different amount of time that they bleed for. Is it heavy cramps? Is it no cramps? We have such variation for it. How long do you bleed? When do you go into menopause? So much variation. But as soon as you're pregnant, it's like, well, 40 weeks. That's it, done. Have the baby out.
Hmm.
Once you're in labor, well, we want to see one dilation centimeter every hour in active labor. And if you don't, that's not the norm. Like we
Yeah.
expect us all to be a certain one way. We do that with babies too, by the way, the growth charts, the percentiles, the normal range, like
Hmm.
we expect babies to all be this like fits one size. But
Yeah.
that we're not like that as adults, right? As adults, we have lots of variation allowed, but in those two arenas, everyone better be pretty much the same. Otherwise, we're going to intervene to make sure you get as close to that norm as possible. That's why it really
Yeah.
matters for a person to make the choice that makes sense to them. And in my opinion, it's okay to say no to your provider. Maybe that's the most radical thing I'll have said in this whole podcast, but like it's okay to say no to your provider if what they're saying does not align with what you think is right for you. They don't have guaranteed results.
Hmm.
By the way, when something goes wrong, they don't blame themselves, do they? Then it's like, well, sometimes these things happen. Yeah, they happen in other arenas too, even when I make the choice. So why is it okay when it's in one place but not another? You know,
Hmm.
if
Hmm.
there's a bad outcome in a home birth, good golly, everybody would be up in arms. But we have things happen in hospitals all the time, but we're not too concerned about that because it's like, well, we did the best we could. Well,
Yeah.
I mean, the statistics show that home birth is just as safe as in hospital. However, a whole lot less interventions will happen if you plan a home birth. So why aren't we planning more home births? You know,
Hmm. Hmm. Or why aren't we designing the labor suite in a different way that serves the person in labor much
that's
more?
right. And we know
Yeah.
that in other places in the world, they have maternity buildings. They have, places where birth centers that are a more of a blended model, right? Here we have a birth center in Toronto. It's run by midwives. It's only attended by midwives. And if somebody wants an epidural or has a medical reason, they transfer out of the birth center. Why can't we have something adjacent to a hospital that's part of, has an intermixed model or how about we just, like in the Netherlands and in certain parts of Europe, it's automatic that you have a midwife first. And then it's
Mm.
assessed. Are you in a category that would require a surgeon to attend you or an obstetrician who has a higher specialty in a specific need? But the default is to have a midwife first. The
Mm.
default here is to have an obstetrician for everybody. And it's still seen as kind of fringe to have a midwife, right? And a lot of
Yeah.
people will assume that if you have a midwife, it's because you want a home birth or because you
Hmm.
want a non-epidural birth. And that's not necessarily true either. You can have a midwife in the hospital with an epidural and still have a little more say in your birth because midwives work a little bit differently than the OBs do.
Yeah. Yeah.
Yeah, why can't we have more of those kind of models of options for out of hospital births? We just don't. But maybe we will
Hmm.
if more people are
Yeah.
doing it, right? If there's more
Yeah.
push for it. If birthing people are not asking for it, it's not going to happen.
Yeah. Yeah. Me and my friend were having the same discussion. Like, why can't we have something that's close to a hospital, but feels very home like a birthing center, but it has that kind of blended model so that in case something happens, in case you need to transfer, it's not like for some people a 45-minute drive, a 1 hour drive in traffic. Like it's close to the hospital and you can kind of just go across a bridge and there you go. So yeah, there's a lot of options. There's a lot of innovation, like room and possibility for innovation in this
Right.
area. I just really don't think it's priority from what I
It
see.
doesn't. It doesn't. And you know, our birth center is connected to St. Michael's Hospital. It's only like a less than 10 minutes drive to get there.
Mm,
So it's not like it's a huge risk. But why do we just have one birth center? It's in the East End. People in the
mm,
North End or in the West End of Toronto might choose the birth center as an option, but it's not close enough for them to feel comfortable that they would arrive in time, right? So
right.
why are we building more birth centers,
Hmm.
right?
Yeah, I
Um,
know.
or encouraging, or you know, encouraging people to just even know their out of hospital options. People don't necessarily know their options.
Hmm.
People don't know that midwives are covered by OHIP.
I know. Yeah. Yeah. My family sure didn't. I didn't know what a midwife was until a friend of mine had midwives attend her births. I didn't know that you could birth out of a hospital until a friend of mine showed me that that is possible. Yeah, it just seems like until you understand that these are options, it's like you don't know what you don't know. Like,
You know what
you
you
know,
don't.
the yeah, like the 4-minute mile. People didn't think that that was possible until someone did it. And then someone did it, and all these people did it like very soon afterwards, right? So we just don't
Yeah.
know that there's a possibility outside of
And
our framework.
you make a very good point too. To that point, you know, why are we not talking about the boring births? Everybody wants a boring birth. You don't want an exciting birth. You don't want the
Right.
birth that was like, oh, it was so hectic and then we arrived and then this happened and it was so scary and then the doctors and nobody wants that kind of exciting birth, but those are the stories that get told the most, right?
Hmm.
Let me tell you about the most horrific story I've ever heard. Well, those get a lot of airtime and then it makes the perception of, well, that's how it has to happen or that's the norm of how it happens. We don't hear those boring stories. Oh yeah, I didn't even know my neighbor was in labor and then the next day I saw she had a newborn baby sitting on the porch. They birthed overnight, midwife came over,
Yeah.
it was over. You don't hear those so much. Those aren't really like, or even the person who birthed like that. When I hear people say, I don't want to brag about it because my friend had such a difficult labor, so I don't want to brag about my easier labor. Like, why are we proud of the exciting, scary labors? Why are we so proud to share those? But we're afraid of offending people when we tell them about our just run of the mill, hey, this is how boring it can sometimes be. I like to call it boring because then don't expect excitement, right?
Yeah. Yeah.
Don't you want just hey, yeah, I woke up, I was in labor, had some contractions, got to the hospital, I was told hey, ready to push, great, pushed out my baby, pretty boring.
Yeah. Yeah.
Why
Yeah.
don't we brag about the boring ones?
I know we should. I do feel like the labor and delivery ward kind of attracts adrenaline junkies. And I know I'm making a huge blanket statement, but it is very exciting to feel like you are saving this baby and you are saving the mom and everyone was running around and you had to get the IV drip in time and you had to do this and there were like 10 practitioners in the room. Everyone's doing something. It is a very intense, almost like the ER type of show, right? It's such an
Yeah.
intense atmosphere. And so I think that is also something we need to take into consideration. Like what is the thought of the practitioners that are being attracted to this kind of work? And I'm sure there are many who are just very interested in helping and bringing babies into this world. Um, but just like anything, like doulas, you're attracting a certain type of person. And naturopathic
That's right.
doctors, you're attracting a certain type of person, right?
And when in Rome, you do what Romans do, right? When you walk into the hospital and it's bright and it's busy and people are moving fast and they're talking loudly, you'll do the same thing. If they wanted to create a calm environment for people to birth, they would have signs everywhere that says, shh, birthing in process.
Yeah,
Like there
yeah,
would be all these indicators that would tell, hey, slow down. We don't need to look at the time. Babies don't care about time, right? Like if we wanted to create a calmer atmosphere for people to birth in, we could do it, but we're not doing that. We're in the mode of like, go, go, go. So you're right. If it's already created as that kind of environment, then you're attracting a person who wants to work in that sort of setting and that sort of environment. And then they're going to also be mimicking it. And then the next person who comes in is also okay to do that, and
hmm
so on and so forth, right? So it's kind of like a big spinning wheel. And how do we get off
yeah,
that spinning wheel? We have to just keep making demands, really. When I first started working in hospitals 10 years ago, They did not have peanut balls or exercise balls in the rooms. A couple of the hospitals even said not allowed. It was a fall risk. They didn't understand how they worked. They didn't want them in the hospitals. Others said, well, if you bring your own, fine, you can use your own, right?
Mm.
If you have a yoga mat, I think I remember hearing that at Northwark General. If you bring your own and it has a yoga mat, fine, you can use it, right? Now, fast forward 10 years, all the hospitals have it. You'd think that the nurses invented it, you know, the way they talk about it, which I'm really proud and pleased that they do, because those are really, really useful tools in labor. But we didn't have those before. And it was only because people started to know its value. They started to bring it with them. They started to demand it. What do you mean I can't have it? I brought it. I brought my own.
Mm.
You know, what do you mean you
Mhm.
don't have it already available? Why don't you have it? Here's, you know, here's so-and-so's really, here's the evidence, here's the podcast, here's, you know, like, unless we're pushing the envelope and asking for that, they're never going to do it.
Yeah, yeah,
Right.
of course, yeah.
The more
It's
that
like
people,
that, yeah, sorry, go ahead.
the more that people ask for it, the more the model will change to adapt, right?
Yeah.
Um, I love, now that you've mentioned Barbara Harper, she's in my mind too, because why why don't we have more water birth facilities available? Right? We're
Mhm,
not prioritizing it. It doesn't give the doctors a very good view when someone is in the water, which they don't love that. So even hospitals that have labor pools or labor tubs typically don't prefer a person to birth in the tub. The
mhm,
caveat is midwives. Midwives are usually okay with the water birth. But why aren't we prioritizing that in the hospitals? Why aren't we encouraging it even? In places where they do have it, there's not even necessarily encouraged that somebody uses water as a tool in labor. Unless parents are doing that research ahead of time and asking, hey, is there a tub here? I'm choosing you because you have a tub. I'd like
mhm,
a tub, you know?
mhm.
Unless we're actually going to utilize the tools and demand that they have them, they're not going to exist.
Yeah. I'm curious if you've seen whether the tubs are even functional and accessible and clean. I've heard some of them are just collecting dust.
Some of them are questionable. I have seen them used. I've even taken pictures when they're used because it's kind of infrequently. I'm like, look at me, I'm at the so-and-so hospital. We're using it's sometimes it is questionable, you know, and again, to the point of, is it more work for the practitioner? Yes. Now they have to do intermittent fetal monitoring, maybe if they don't have wireless bands, they have to use the Doppler, it goes in the water. Do they have the gloves? Sometimes,
Mm,
you know, does the birthing person have to stand up to be able to get that listened to, the check? You know,
mm,
is it clean? Is there a stool to sit on inside? Is there towels available? Sometimes you get in the room and there's only 2 towels. How are you going to get out of a bathtub and then not be a fall risk as you walk back through the room?
right.
Um,
Yeah.
so that's definitely a thing to if someone is looking to labor and they're choosing a hospital because it has a bathtub, to find out, is the bathtub usable?
Yeah. Good
Right?
question. Good question.
And will I have a bathtub? Mount Sinai only has a couple of rooms that have a bathtub. So they get
Mm,
used frequently because the midwives tend to use them. But if someone's not asking for it, they're not automatically going to get that room with a bathtub.
right. I have heard of people using the bathtub or like laboring in water to prevent touches because once you're in the water, it's more difficult for
A lot
the
more difficult.
practitioners.
It's a
Yeah.
lot more difficult for somebody to be doing that, you know, even the checks to the stomach, which maybe you want those, right? I'm not saying
Hmm.
not to, but vaginal exams during pushing to be able to assist with the vaginal stretching or even pressure on the perineum. Like, it's much harder to access the body when someone is in water, for sure.
Hmm. Hmm.
But that's also,
Absolutely.
I've seen as a reason to ask a person to completely come out of the bathtub. I've seen that
Right.
as, well, we cannot do this kind of exam here and we'd really like to. So can you come out of the water and come lie down on the bed and then you can go back in. But again, in the moment of active labor, do you want to be doing all this back and forth? It might be discouraging. Once I'm out, well, now I'm out. And by the way, if I'm coming out because I'm already fully dilated, now I've laid down on the bed to get that cervical exam. So I'm flat on my back, my legs are spread or maybe like feet together. I'm told I'm 10 centimeters. Hey, let's have a practice push. You do one practice push with someone's hands in your vagina. They get very excited. Wow, you're moving the baby. This is great. Keep this position.
Hmm. Yeah.
So even if you
And there you
think,
are.
oh, well, I was in the bathtub, that's where I was going to do it. But now we just did this practice push and I was told that it's effective pushing, so I better just stay here because it's a better place. Unless that person who's giving birth says, I'm going to get back up and go into the bathtub. Unless they do it and say it, it's not going to happen. Even in some cases, having a doula there saying, hey, how about a position change? How about we get back into the tub? That's not necessarily going to be enough for the practitioner to be like, great, let's get in the tub. They might be like, well,
Mhm.
no, this was working better, right?
Yeah.
Unless you yourself who are giving birth, unless you yourself get your body up, rotate your body, get out of that lying down position, no one else is going to force you out of it. No one else can
Mhm.
be the one to say, no, no, come on, get on up. Because your doctor or midwife won't necessarily do that. They might suggest a position change, but they might not. So it might be up to you to go, I'd like to try something else, or I want to go back into the water. So the
Yeah.
water, the birth tubs are commonly more for labor than for actual birthing. But again, the more people say, hey, I'm staying in here, I'm already pushing, I'm not getting out, then the doctors are just going to have to adapt and learn how to still be able to attend safe birth. It's their
Mhm.
job to learn how to attend you in birth. When a doctor says, well, healthy mom, healthy baby, thank goodness everyone arrived and you're going home alive, I'm like, you just did your base minimum.
Mhm.
As a doctor, don't you hope everybody survives your practice today? Like, so
Mhm.
you did your bare minimum. You don't care about the experience of it. You don't care that none of that was their birth wish.
Mhm.
Maybe the person had forceps and an episiotomy and their baby has a little like, scalpel laceration. You're like, well, at least they're alive. It's like, well,
Yeah.
you just did your minimum, really. Like, what about all those other things? What about, trusting people's bodies and intuition and giving them the experience that they know they can do? They know they can have that experience until you tell them they can't.
Mhm.
Want to congratulate yourself for saving their lives. That's your minimum. That's your bare minimum.
Yeah, yeah. On that note, I want to kind of just get your take of what you see happening in the world of birth in general, how you see birthing people, how you see women and their partners kind of advocating for themselves, empowering themselves, or not, depending on your experience. And also, I want to bring up the fact that, like, because of all of the things that you're talking about that you're seeing in the hospital, and it sounds like you deal and support women with traumatic birth experiences afterwards, um, a lot of women are feeling like they are almost forced outside of the hospital system, or and are leaning towards free birth, even if they don't feel like that is the safe option for them. Like, what's your take on all of that?
Um, yeah, I have seen some of that where it almost feels like, you're choosing the lesser evil. Like, I wish I could have a safer option, but because that one is so seemingly unsafe, I better take this other option. I'm kind of excited with some of the way that birth is going because even things like TikTok and Instagram, like it's giving us so many more views of how labor can be, right? I'm not trying to say that everybody should birth the way I think they should birth. I think everyone should have the full scope of what it looks like. Here's the very medical side of things, and here's, the free birth at home. Where do you fit on that scale? You should be allowed to freely choose based on what makes sense for you, for your wishes, for what your intuition says is the safest way for you to birth. It kind of hurts my heart when someone is choosing not that, right?
Mm.
I'm not choosing home birth because I love home birth. I'm choosing it because it's not the medical model that I want to avoid, right?
Mhm.
That's again not so empowering. But I feel hopeful that we're in a place where there are more doulas than ever, right? We've never had so much knowledge of doulas and practitioners who are in this work. I don't think we've ever had as many lactation consultants as we do right now, and even that is altering how birth itself happens, knowing that you have somebody to help you in that after stage. I feel like there's a lot more modalities of empowering our bodies. So I think the more we're doing that, the more we're going to see people changing the way the hospital birth is going. For instance, I did have, I think, 3 people last year who reported back from my classes that the dad had caught the baby
Oh,
and they were very
nice.
excited about it. And it's the kind of thing that until someone suggests that it's possible, they weren't going to do it. right?
Mhm.
And then
Mhm.
afterwards, they can tell their friends too, like, hey, did you know this is possible? And maybe it's not just the act of catching the baby, but it already gives the implication of like, wow, that's not so scary, dangerous as I thought childbirth had to be.
Mhm.
You know, if my neighbor Joe could catch a baby, well, then that's probably like not such a complicated event after all, is it? Right. So
Yeah.
I think the more that we have, you know, influencers who are on either side of the birthing world, you know, whether it's medical or non-medical, the more we see different ways that people birth, the more we get the full options of what's available. If we don't know what our options are, we're not going to choose differently than what's just presented to us. So I do
Yeah.
feel like although our rates, it's 97% of Ontarians give birth in hospital. I don't know that we're going to see that go drastically down, but I do feel that we are slowly changing the way that the hospital is working, and
Mm.
I think we're going to see more of that. So I'm kind of excited for that. I think we're on a good trend, Dr. Cindy. I don't think we're getting worse. I think we are getting better, and part of that is that people are getting their own information, you know, taking classes and bringing their partner to classes. It hasn't been very many generations where we've invited dads and partners into the birth arena. They don't necessarily have their own dad to ask, hey, how was it when you attended my birth in hospital? Because maybe they did,
Mhm.
right? So even that is a very new thing in our North American culture and our Canadian culture to have partners attending as the primary support person. So they're also changing the way the birth world works. They get to ask questions, they get to witness what's happening, you know, they
Mhm.
get to have a say as well. So I think that's all very positive things.
Yeah.
I think we're going to
Thank
see more
you.
people birthing out of hospital. And I do think that we're going to see more free birth and birth attendants who are not registered. I do think we're going to keep seeing more of that because people want choices. And I think
Mhm.
that we shouldn't vilify people for making choices because what's dangerous to me is not dangerous to you. And
Right.
if we agree that adults get to make decisions for themselves that make sense for themselves, then we have to let them make those decisions, even if we think that it's not safe for them.
Mhm. Mhm. And that's autonomy, right?
That's
We're
autonomy.
individual, hopefully free people, and we
That's
can
right.
make those decisions for ourselves.
The reason it gets complicated in the case of childbirth is now we have a vulnerable person in the body who also has to have someone make decisions for them. So then the question
Mhm.
is, am I, as the person carrying this baby, making good decisions for this other person?
Right.
Right.
Yeah. Yeah.
Like on the
Good
extreme side of
question.
it, if a medical provider fears that that you don't make good choices for that baby, they can call Children's Aid Society and make an assessment on whether or not you should leave the hospital with your baby. That's kind
Mm.
of an extreme situation, but not for certain populations. That's more common in younger people birthing, people of color birthing, single people. You know, they have a little different scrutiny of, are you actually choosing well for yourself? Are you allowed to choose for yourself? Or is it going to be
Mhm.
scrutinized as like, oh, if you're not making a wise decision now, are you going to continue making wise decisions for your baby? Yeah, I think
Mm.
that's a form of violence that we impose on people too, this threat of taking away children or taking away your choices. If you can't make good decisions for yourself, we're going to take away your ability to make those choices. That's not my philosophy. I think as adults, you should be able to make that choice. And if it's dentistry, again, if I'm told, hey, you should get a root canal, if I'm like, nah, I think I'm going to just live with it and not get the root canal, okay, well, that's your choice. Maybe
Mhm.
it's not a wise one, but I still get to make that choice. But in obstetrics, you better not make the wrong choice based on what a provider thinks.
Yeah. Yeah. It opens up a whole rabbit hole,
And even
definitely.
as doulas, you know, one of the things that I'm not, as a certified doula, one of the criteria is that I'm not allowed to advocate for free birth. I'm not allowed to connect somebody to a free birth. I'm certainly not allowed to attend a free birth. That's not part of the certification, is for me to attend without a midwife present or a doctor present.
Mm.
And even that, I feel like in some ways it feels a bit restrictive to that birthing person. So now you're limiting who that person can choose at their birth because I'm not allowed to attend it, right? I'm
Yeah.
not allowed to tell you about free birth. Even though I
Mm.
feel like my role as a doula is to give people the full range of here's how people birth. Where do you see yourself in this range? And
Mhm.
maybe you're actually going to create something that's completely outside of that paradigm too.
Yeah.
Imagine there's a way to birth that we've not even figured out yet. Maybe there's a
Mhm.
whole other way that we've not even seen.
Yeah. We don't know what we don't know.
We don't know what we don't know.
Yeah.
We're only ever going to go one pathway and be like, here's our best model. Go to the doctor
Mhm.
and be in the hospital and have this, this is the checklist of the way we go through it. Then we lose the ability to have the choice to see all the different ways that are possible.
Yeah. Yeah. Big
I wish,
disservice, right?
I kind of wish that part of the practice of anybody who's working in the birth world, that they have experiences outside of hospital, just to
Mm.
be able to have that full view. That's one of the unique views that a doula has. Because we're
Mhm.
not medical practitioners, we have clients that could be at home, they could be at the birth center, they could be at the hospital. So we end up seeing the whole range. Some practitioners say, hey, we have 72 hours before we start worrying about infection after we rupture your membranes. Another hospital says 12 hours. Right. So then we see the whole range of what can happen. And when a doctor says, like, oh, it's never going to happen that way. Babies cannot be born that way. It cannot happen. Then they're
Mhm.
like, well, I saw that once at a home birth. That's anecdotal. It's not to say that everyone's going to be able to have that happen, but you can't tell me it never happens because I saw it.
Yeah. Yeah.
Sunny side up baby. I had someone say that. Babies cannot be born face up. It doesn't work that way. It cannot be. We're going to have to turn that baby one way or the other.
Mm.
That's not true. My niece was born like that, poop, like a turtle,
Mhm.
face first.
Yeah.
It was
Yeah.
not easy, but also possible. We
Yeah.
can do hard things. That's my motto. We can do hard things.
Mhm. I
And
love that you said that. It's like, sure, this is gonna be difficult, but also you can do things that are difficult. And that's such an empowering message for anyone who is listening to hear.
when I had my first baby, I basically told my partner, I'm dying. This is it. My eulogy. Take care of me. I'm so sorry I won't be there with you. I was really hoping to have this whole experience, but I don't see any end for me other than just like, I'm giving up. Do your best. Right. And then I pushed out this baby. And I remember just feeling like, and he's a big guy too. He was a bouncer, right? So he's a big, tough, strong guy. And he's crying and he's like, you're the strongest person I've ever known. I've never seen anything so strong. And I just felt like an Amazon. I'm like, yeah, baby. You, like live to tell. Why would I want someone to steal that from me?
Mm.
Would I have wanted a doctor to come in and go, oh, honey, I don't want to see you suffering. Just have an epidural. I'm not suffering. I'm enduring the hardest thing I ever experienced in my life. And I survived it and I live to tell. I'm a freaking Amazon. And I'm not
Yeah.
saying everyone has to do it that way. I'm not saying it goes like that for everyone. But for me personally, that's how it went. And I'm glad that my experience went that way. And it was not easy. And I did have a tear. And my baby did have her neck wrapped with her cord, and she did have resuscitation, and she did have a lot of other stuff, right? So it's not to say that like everybody gets a perfect everything, but I felt really great about every choice I made. So am I lucky? Maybe, but also I had a really good team. It was really supportive. And I didn't have someone come in and say, oh, can I end your suffering? They just said, you can do this. And I did.
Mhm.
And now I
Mhm.
know myself as someone who can do it, right? Then when someone
Yeah.
says, hey, you know what, that's pretty hard. You should just give up on that. I'm like, you don't even know what I'm capable of. You
Yeah, it's so empowering, and it is that initiation into your power that I speak about, and many women and many people in the birth world speak about so much. Like it is your like you're getting ready for motherhood, which also is not easy,
it's
right? And
also not
so
easy.
yeah, yeah,
And
and so having that empowerment.
even if someone's birth gets derailed, right? Even if, okay, at the end, I pushed for 3.5 hours and then I had an episiotomy and then they used forceps and then my baby needed some recovery time in NICU. Even if you ended up with all those things that you didn't want and didn't anticipate, at the end of it, you can still come to a point where you can see yourself as that Amazon. You're like, look at how much my body can endure.
Mhm.
Look at how much I can recover from. Look at,
Mhm.
despite all of the way we started and the separation I had from my baby, look at how I was able to bond with that kid.
Mhm.
You can still feel proud of every single birth that we have and avoid all of those unnecessary things along the way. But if we can't avoid them, we can still have it be, you know what, I made those choices because in the moment they were the best ones I had, and I'm going to
Yeah,
stand by them, you
yeah,
know?
yeah.
That's my goal as a doula, is for people to stand by the choices they make, even if it's yeah, it led to a prolapsed cervix or a prolapsed uterus, and I had to do all this work. We don't wish that to happen, but we can survive that too and be resilient and use that as like, you know what? Maybe the next one I'm going to do differently because I want to avoid something, or maybe not, right? Maybe it's I did everything I could and that's just how it was going to go. But
Hmm.
live to tell, right?
Yeah, absolutely. I love that message. And it brings me to my last question of the podcast. And you may have heard this before, but the introduction to this podcast is let's imprint love, safety, and trust onto the next generation, which are all signatures of oxytocin, as you were saying. And unfortunately, sometimes that's not what's imprinted onto this new life that's entering our reality. And that's okay. And it's not permanent, and we can do things to repair whatever happens. And as you said, I love that message of like, no matter how things go, the fact that I can be resilient and look what I can endure. And when parents show their or like express that resilience, that also imprints something onto that new life, right? And so it's not a be all end all what happens in the birth, you know. Um, but with that being said, what would you like to imprint onto the listeners? And it is a lot of, you know, women and their partners in the preconception phase. Excuse me, maybe they're pregnant, they're preparing for birth, they're doing as much research as they can, or even people in the postpartum period, and maybe there's a little baby listening as well.
Well, I'm glad that you brought up oxytocin and you know, your tagline for the, you know, how you describe the podcast, because oxytocin is not just about love, right? People can be very fierce in their birth and still have a lot of oxytocin surging. That trust and confidence piece, we're not really thinking about that as much. And cortisol and oxytocin are in balance in our body. It's not necessarily bad. If I'm having a response and my body is giving me extra cortisol levels, it's because I need that balance to be able to be resilient with whatever I'm coping with and dealing with. So if we can trust that we're always having, our body is always giving us what we need in the moment to be our best selves. If we can trust that, then we know that we can inspire it to do more of that, right? You can always bring your oxytocin back. Your partner can help you bring that oxytocin back. But the more we have fear and anxiety and we allow the space in our brain to give more time to those fears and anxieties, we're having trouble having that oxytocin catch up, right? So if I could leave one nugget of information, people already have everything they need to give birth. They already have it. It's already in our DNA. It's how we were made. We're already made to reproduce. It's how we're made to exist, right? And it's
Hmm.
not to say that every single person will reproduce. It's not to say every body will have a baby, but we do have the cocktail available. The means is there. It's not an alien we're growing. It's the most human experience we're going to have, actually, is when a baby's in our belly. But this whole mystery, let's take the mystery out of birth, right? Like it's not so mysterious and unknown. We've literally been doing it for many, 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 many generations, and we're going to continue to do it for many generations. So if we can trust that we have everything we need, turn off the brain and just let the body bring on what it needs, that kind of says that every person has the ability for it. It's
Hmm.
possible. And then maybe just little nudges, right? Nudges from your partner to bring it on, nudges from your team, from your doula. Like we have the ability for it, but if we don't believe that we do, we won't be able to do it. So we got to
Yeah,
trust more in ourselves and hone our intuition, right?
yeah,
Intuition
yeah.
matters for me anyway, a lot.
And to me as well, and definitely in the birthing experience and in parenthood. Yeah,
And the more you can
it's a
trust your
superpower.
intuition, that's right. The more we trust our intuition, the more confident we are. And there's our oxytocin. That's bringing on more of that confidence and trusting feeling. So
Mhm.
you know, the roles for partners, the biggest role is being the person that she loves most in the room, the person she trusts most in the room, you know, the person
Mhm.
who can change the mood real quick, right? You can
Yeah.
shift the mood from scary, sad into curiosity, joyful, real fast, more than the
Mhm.
doctor can, right? Like to be able to impact, to be able to see that the worry lines are showing up, right? That thing that smooths it out, or to be the comedian, like the role of the partner is so big in keeping that confidence going and the trust.
Yeah, absolutely. And so I'm hearing a big message about trust
Big message about
coming through.
trust.
Yeah,
Oxytocin, when we're too busy thinking about love, that's not all of it. That's not the whole part of it.
yeah.
It's not just about love. What if I can't be loving in that moment? What if I don't love my partner? What if I don't have a partner? Does that mean I
Mm,
don't have oxytocin? No. But I think that the more we can trust our bodies, trust the process, trust your intuition. If your intuition says, that sounds like a bad idea, doc, maybe there's something to it, right?
mhm,
Don't
mhm,
ignore that you don't agree with what your doctor's telling you. I think that's very, very powerful. Trust that trusting of the intuition, even when it doesn't go to plan, trust that the next time will be different. That's what's going to
yeah,
have our oxytocin soar. And then hopefully
mhm,
need it artificially given.
yeah, absolutely.
Yeah.
Vera, this conversation has been so illuminating. I think the fact that you have experience in several different hospitals and have seen so many and attended so many births and supported people, supported couples along the way, you're just such a wealth of knowledge and wisdom. And I really appreciate the work that you do. It's truly, truly valuable. So thank you so much. I'm so happy that we crossed paths. Yeah, just very serendipitous.
Yeah, I'm really glad we had this chance too. I can talk on and on, as you see. I'm pretty excited to have somebody asking me all these questions. So thank you so much for having me on. And um, I hope that there's comments. I'll pay attention to if there are any comments. I'm going to be keen to respond to because I do think these topics are important, and I'm happy to be here and talk about it.
Yeah, they really are. And if anyone is interested in working with you, reaching out to you, how can they do that?
doulasonbikes.com. That's my website. You can see my bio. I'm available for birth doula work. I teach childbirth classes. I have an online class starting July 28. It will be 4 sessions Sunday morning. So they can visit the website, and my contact information is there as well.
Beautiful. Thank you so much. We'll link that up in the show notes for everyone. And I, again, appreciate you and I hope that we connect again.
Thank you so much.